That sounds good, Doc.
Okay, perfect. Thank you so much. 2 minutes. Then we are going to start our session, right?
Yes, Doc.
1 minute to go. Please just text in the group if someone didn't receive the notification so that they can be, aware of that and join the session. Okay. So can you guys just see my screen? Hello? Hello?
Yes.
Okay,
Yeah.
perfect, perfect. So let's start our today's session, right? So we'll be starting from platelets module. And we know that the first topic which we are going to discuss is homeostasis. So what is homeostasis? We discussed that homeostasis basically is a group of mechanisms. Like, for example, if there is certain changes in your body, like for example, if I have a person, he's going to, like, some environment which is very cold. So what his body is going to do, his body is going to adapt certain mechanisms in order to keep his internal environment constant. So in order to have very less impact of the stress, the external environmental stress, our body have to do certain mechanism. It have to adapt according to that. One of the mechanism which is highly specific to this module platelets is going to be like primary and secondary, homeostasis, right? So let's discuss two kinds of homeostasis, and in this we'll be specifically, mentioning the role of platelets in this homeostasis. For example, let's suppose if you have an individual, he have certain, like for example, if he have a cut on his skin, right, and his blood vessels there in the skin, they are cut off and they are a kind of ruptured. So what happens now? There is increased chances of blood oozing out of the blood vessel, which isn't good. It can lead to shock. It can lead to hypovolemic shock, right? It can lead to a lot of infections, and a lot of bacteria can enter there. So for that, our body have adapted certain mechanism, right? So we'll be discussing that. So the first mechanism is primary hemostasis, which is going to be the primary mechanism or adaptatory pathway in order to prevent this blood loss. And we have secondary homeostasis. So can anyone just tell me what is primary homeostasis? We already discussed it in a big detail. So I want you guys to participate. Please raise your hands. Anyone who want to participate, please. Yes, please. Hello, can you guys hear me?
Yeah, making the clot.
Yes, okay, perfect. So in primary homeostasis, the main idea is that the platelets are gonna come here and it would just try to block off the ruptured part or the ruptured area of your blood vessel, right? So mainly the platelets are going to be the main, savior of of our hemostasis. And what's the secondary hemostasis? In secondary hemostasis, we are going to activate, your body is going to activate certain mechanism, for example coagulation cascade. Why? What's the goal of that? In order to strengthen the platelets plug. That's it. So let's discuss Primary hemostasis in a little bit more detail. For example, if I had a cut, so what your body is going to do initially, what would be the step one? So step one is going to be your, okay, it's your step one is your vasoconstriction. We already know that the main vasoconstrictor present inside your endothelium is going to be your endothelin. We know endothelin is vasoconstrictor and nitric oxide is your vasodilator. We already knew that. So first of all, we need vasoconstriction. We need vasoconstriction in order to close off this ruptured area. The idea is really simple. So endothelin will just come and it would try to block off the ruptured or the punctured area, right? What next gonna happen is step two. What happens in step two now? Platelets would come there and platelets would attach to this area, to this ruptured or punctured area. But we guys already know that platelets directly cannot attach there. First of all, you need a king, you need someone in order to do this interaction of endothelium with platelets. Yes, Dr. Lily, can you just tell me what's that king which we are discussing?
Uh, uh, Volvinogram factor,
Okay, perfect. So one relevant factors are going to come here. Like for example, if this is your, let's suppose, endothelial area which is ruptured, so one relevant factors are first of all going to attach there, and then your platelets are going to come and it's going to attach to the area where we are seeing blood oozing out, right? So can you just tell me which receptor is important, or through which receptor platelets attach to one relevant factor? Very important. What's the name of that receptor?
GP1B,
Perfect, GP1B. Okay, now we have platelets attached to your von Willebrand factor. So now we also need a lot of platelets to attach with platelets as well, right? We need platelets to platelets adhesion as well. We all are aware of that, right? So basically, this was platelets to von Willebrand attachment through GP1B. So can you just tell me how do platelets attach to other platelets? What receptor do they use?
GP2B,
Perfect. GP, 2B, and 3A, right?
3A.
But in between this interaction, like for example, if this is your platelets attaching to other platelets, so in between fibrin is gonna come, right? And fibrin, we know what is fibrin. It's the goal of your secondary hemostasis, your coagulation pathway. In the end, it gives fibrin, right? So for the strengthening purposes of platelets to platelets adhesion, secondary hemostasis is gonna come into play. Is that clear?
Yes.
But a question arises that, for example, if now I have this single platelets, how this single platelets attached to one relevant factor tell other platelets to come please and join me close of this punctured, right? What substances or what chemical mediator do platelets release in order to call other platelets? Yes, anyone who can just tell me, please.
Thromboxane A2.
Okay, perfect. Thromboxane A2, ADP, right? Like your platelets is going to degranulate, it's going to dump off ADP, it's going to dump off thromboxane A2, and these chemical mediator ADP, thromboxane A2 would just guide other platelets to come and participate in this closing of this punctured area. Is that clear? So that was basically platelets to platelets aggregation via which receptor? GP2B3A. And in between, fibrin is gonna attach there, right? So let me just indicate fibrin with the color red. Is that clear?
Yes.
Hello?
Yes.
Okay, let me just ask a question from you guys. For example, if you have an individual and genetically he is unable to produce GP1B, these receptors are deficient. We do not have these receptors, for example, due to some genetic cause. What's the name of that pathology or that qualitative disorder? Yes, please raise your hand. Okay, Dr. Daniela, what do you think?
It's called Bernard-Soulier syndrome.
Perfect. It's known as Bernard Solier, right? Okay, again, if I have another individual and genetically he isn't having the capability to make GP2B3A, what's the name of that qualitative pathology?
Glanzmann thromboasthenia.
Perfect. Lanzmann's thrombosthenia. Perfect. Right. This was all about primary hemostasis. For example, if we have an individual and something get wrong with his primary hemostasis, so we are going to see some clinical features that's obvious, right? So we already know, right? A common rule of thumb which you guys should be aware of. This is going to help you in solving a lot of MCQ, right? So primary homeostasis is basically important for bleeding which are occurring superficially, right? Superficial bleeding. And for example, the secondary hemostasis, which was basically used for strengthening your platelets, right? Secondary hemostasis, it's responsible basically for in order to avoid deep bleeding. Is that clear? Hello?
Yes, sir, it is.
Okay, so in your MCQ, whenever you see superficial, what are superficial bleed? All of the mucosal bleeds, right? Mucosal bleeding, for example, what are mucosal bleeding? Epistaxis, it can be menorrhagia, it can be a lot of things which are basically dealing with epithelial bleeding. All of that indicates that you have problem with your platelets. Is that clear? While deep bleed, what's the example of deep bleed? For example, bleeding into your joints or bleeding whenever the bleed do not stop even after, for example, surgical, removal of your tooth, right? That's also an example of deep bleed, right? So you should be taking these things into consideration. So coming towards disorders of primary hemostasis, if you have superficial bleed, right? Superficial bleed. So how would it appear? We already discussed. It can appear like in the skin. In the skin, we have three variants of that. Dr. Danvila, can you just tell me the three variants which we discussed based on the size of bleed within the skin?
Yes, we discussed the petechia, the ecchymosis, and the
Petechia,
yes,
ecchymosis,
and
and
purpura.
purpura.
Yes.
Purpura or purpura. Perfect. That's perfect, right? So these are gonna be your clinical picture, which you are gonna see in your UL MCQ. So Dr. Damila, can you just please tell me the normal concentration of platelets present inside our body? What's the normal limit or normal range?
150,
150,000 to
150, okay, 150,000 to 240,000, if I'm not mistaken.
Okay, perfect. Okay, like round about 400K, right?
40,
Perfect. Okay.
400,000.
Okay, perfect. That's perfect. Let's discuss our next pathology, that is immune thrombocytopenic purpura, right? Immune thrombocytopenic purpura. Anyone who just want to participate, please raise their hands. Dr. Hazira, can you just tell me what does the name indicates? Immune thrombocytopenic purpura. Yes, what do you think? Dr. Hazira, can you just please turn on your mic? Okay, anyone else, please raise their hands. Dr. Muskan, yes, please.
Yes, doctor.
Okay. So my question is, what does the name immune thrombocytopenic purpura suggest? What, like looking to only towards the name, what
Yes,
can
doctor.
you like derive of, or you can think of looking towards
Okay.
only the
I by the name we can understand that thrombocytopenic. It means thrombocytes are reducing because of
okay.
some immune
Less
reaction.
platelets, right? Less platelets.
Yes.
And we already discussed less platelets lead to purpura, right? Superficial skin bleed. And
Yes.
immune means this damage or this, decrease in platelets have to deal with some problems within your immunity, right? Or some autoimmune diseases or some autoimmune problem can cause death of the platelets, which further leads to purpura. Is that clear?
Yes.
This is like something which we can just only look towards the name and we can think of. That's so clear, right? So we have already broken down this pathology, we already know the concept, so let's dig a little bit deep. What happened in this process we already discussed. For example, we discussed spleen is the major reservoir of your antibodies, right? Like even half of your antibodies come from your spleen, right? So for example, what happens in this pathology, that there is some problem in your spleen would just produce antibodies against your platelets, right?
Yes.
Okay. Once the spleen produce antibodies against the platelets, what happened? You have antibody and platelets, right? So spleen is going to make some autoimmune antibodies, right?
Yes.
Autoimmune antibodies against your platelets. And this complex again is going to be tagged. It's going to be entering your spleen, and spleen again is going to eat it, right? It's going to kill them. Is that clear?
Yes. Yes.
Okay, so if the spleen is killing again these platelets, so can I say that all of the problem arises from the spleen? Why? Because spleen is making some abnormal antibodies, and spleen again is eating up all of my platelets, which is giving me purpura, right? Can I say that?
Yes.
So one of the treatment option, can I say it can be splenectomy?
Yes.
Okay, so splenectomy. So spleen is the culprit here, right? So if the spleen is culprit, one of the treatment option, remove the spleen. But whenever we remove the spleen, we have a lot of problems. You guys have seen a lot of MCQs on that, right? There is
Yes.
increased chances of having encapsulated bacteria, right?
Yes.
Why? Because in immunology section we discussed that in order to eat or kill your encapsulated bacteria, you need antibodies that should tag them, and major reservoir is spleen. If you just remove the spleen, you will be seeing what you will be seeing:
We-
infection with encapsulated bacteria.
Yes.
That's right. So you're going to see this MCQ in U word. You guys are already done with the U word, so you guys are aware of that, right? Okay. So let's just come discuss some of the lab findings. The idea is really clear. We have less platelets, right?
Right.
If you have less platelets, can you just tell me what happens to PT or PTT? You guys are already aware of PET and PTT. What would happen
Not
to
normal.
normal? Perfect, because it's pathology of your primary homeostasis. You
Yes.
have nothing. It have nothing to do with your secondary homeostasis, the extrinsic and intrinsic pathway. So we are gonna expect the PT and PTT to be same or normal, right? Okay, what else we can do? If you remember, we can distract the spleen as well, right?
IG.
Dog approaching towards you, so you are gonna throw
I
some piece of bread. Perfect. IVIG, right? You have a UL MCU on that as well. So what we can do, we can give IVIG, right? So what happens? Your spleen are gonna be distracted. They'll be eating your IVIG, and in this way, we can save these platelets from this culprit spleen, and you will avoid like you're gonna avoid thrombocytopenia and purpura, and you're gonna decrease the pathology to certain extent. Is that clear?
yes.
Okay, perfect. So the next topic which we'll be discussing is MAHA, MAHA, or to be very specific,
And
microangiopathic
anemia.
hemolytic anemia. So let's break this name down. Microangiopathic hemolytic anemia. So you can see micro basically stands for some small thing, right? Some small, right?
Yes.
So it means
Yes.
you're going to see some problem in some small thing. What's that small thing?
Blood.
Angio for your blood vessels, right? Blood vessels, pathic, you have certain pathology, right?
Yes.
Which leads to hemolytic anemia, killing of your red blood cells. Can I say that?
Yes.
Perfect. So now the question arises that we already know. We are going to have pathology in small blood vessels, which leads to killing of your red blood cells, as the name indicates. So the next question in your mind should be, what's the pathology? So the pathology is sometimes what happens, for example, if this is your blood vessels, you can have a lot of meshworks, right? Meshworks. What meshwork? I'll be just discussing that soon, right? So you're going to see a lot of meshwork. That is going to be the pathology seen in Maha. Now, next question arises in our mind. What's this meshwork, right? So sometimes you can have overactivation. Okay, let me just emphasize on this point again. Sometimes we can have overactivation of your both primary and secondary hemostasis, or you can have overactivation or a lot of platelets present here in the small blood vessels. We will be discussing the cause of that, which can lead to this meshwork kind of thing. And whenever the red blood cells are passing through this meshwork, what happens? They'll be teared into pieces, right? They'll be
Yes.
teared into pieces. So when the blood vessels are teared into pieces, so
She's
now it would lead to
helmet.
hemolytic anemia.
Yes.
Hemolytic anemia, right?
Yes.
Okay. And specifically, whenever they are sheared or tear down into pieces, it would just give you a characteristic structures known as schistocytes. You have a you got MCQ on that, right?
Yes.
Schistocyte. They are basically the tiered red blood cell. They are also known as helmet
Helmet.
cells. You were MCQ on that. You already have done that, right?
Yes.
Cystocyte. So now let's discuss a little bit more in detail. What drives this meshwork to be formed? We already know that this meshwork can have a lot of platelets, a lot of fibrin, a lot of primary hemostasis pathway component, or a lot of secondary hemostasis pathway. So the next question arises that how do we get that meshwork there in the small blood vessels, right? That should be the question. So we have a lot of conditions, right? A lot of condition can do that. One of which is TTP. What is TTP? Thrombotic,
Thrombocytopenic
thrombocytopenic purpura,
purpura.
right?
Yes.
Thrombotic, thrombocytopenic
Purpura.
Purpura. Let's break down this name. Thrombotic. It means we are going to see a lot of thrombus, right?
Yes.
Thrombocytopenic. Due to that thrombus, the platelets are very low. Thrombocytopenia means low platelets, right? It means that this thrombus is made up of platelets. Can I say that?
Yes.
Like thrombus can be of made up of blood cells, it can be made of anything, right? Platelets, is it right? So whenever
Yes.
we see the next name thrombocytopenia, it means that now the thrombus is made by your platelets. These are the platelets which are making your thrombus, and whenever platelets are making thrombus, you're consuming the platelets. Once the platelets are consumed, we are going to see thrombocytopenia. Whenever we have thrombocytopenia, less platelets, that's obvious we are going to see superficial bleed, purpura, right?
Yes.
That's obvious. So now a question arises that how can we have this platelets thrombus, right? So the answer for that is that we discussed we have von Willebrand factor, right? Von Willebrand factors. But initially von Willebrand factors are released in a form of multimer, right? Simply you can think of a big ball, right? But in order to get small von Willebrand factor, it means we must be having an enzyme that can cleave this big ball and give us normal small von Willebrand factors, which we already know, which have TP1B, which attach platelets towards itself, right? What's the name of that enzyme? Adam.
TS13.
TS13, perfect. For example, if you have any problem with this enzyme, how can we have problem? Let's suppose your immune cells are killing Adam TS13. What happens? Now you cannot break down this big multimer into the small monomers. So what happens? This big multimer is gonna come, it's gonna attach to the surface of your blood vessel, a big multimer, and it would just, redirect a lot of platelets to be present there. And in this way, you can see a thrombus which comprises of platelets and a pathology TTP. Is that clear?
Yes.
Once we have this pathology, you can see we have a meshwork, right? A meshwork of cells coming there, lying there, giving you MAHA. Whenever we have MAHA, microangiopathic hemolytic anemia, you can see tearing down of your red blood cells, schistocytes. Is that clear?
Yes.
That's perfect. Okay, so let's discuss our next pathology. Okay, so let's discuss it in a little bit more detail. You also have another pathology, HUS. HUS can also do that, right? Hemolytic uremic syndrome. You have a UWorld MCQ on that. So the first question which should arise is that what happens in HUS, hemolytic uremic syndrome? It means you are seeing the word uremic should just indicate that you are going to see involvement of your kidney, right?
Yes.
Hemolytic, you are going to see hemolysis, breakdown of your red blood cell, and it's a syndrome. It means it's accompanied by some other things, some other clinical features as well, right? So what happens in hemolytic uremic syndrome? The first question which arises: how do we have hemolytic uremic syndrome? What's the main cause of that? Yes, Dr. Muskan.
Doctor, it is the cause because of sugar-like toxin which is produced by E. coli.
Perfect. So E. coli sugar-like toxin can do that, right? What happens? It produces a toxin which is known as virotoxin. Virotoxin can cause a lot of damage, and a lot of damage. What a lot of damage do? Primary homeostasis, a lot of platelets there, right? Lot of
Yes.
damage, lot of platelets. Again, definition satisfied. A lot of platelets. We have MAHA, we have meshwork. It can kill, it can tear off your red blood cells, right? So, can you just tell me some of the clinical findings of HUS?
Yes,
Yeah.
doctor. Such as fever, renal
Okay.
insufficiencies.
Perfect. Renal insufficiency in specifically in hemolytic uremic syndrome, right? Like it can
Yes.
involve the renal artery as well. What would be
Yes.
the lab finding? The idea is really simple. Lab finding suggests decreased platelets, right? Okay. So in order to look for the activity of platelets, basically we use a term that is known as bleeding time, right? So what is bleeding time? Yes, what is bleeding time? What is normal bleeding time?
2 to 7 minutes.
Okay, 2 to 7 minutes. The idea is whenever we have a superficial bleed, we are going to wait for 2 to 7 minutes in order to stop that bleed. And we know for superficial bleed, platelets are an important factors, right? So bleeding time basically is going to tell us that if your platelets are working or your primary hemostasis is working or not. Is that clear?
Yes.
Perfect. So let's discuss secondary homeostasis in a little bit detail, right? This was all about second of primary hemostasis, the main concepts. Let's discuss secondary hemostasis. Okay, so we discussed what's the main idea of secondary hemostasis. Basically, in secondary hemostasis, we are gonna see, strengthening of the platelets plug. How? We are gonna see fibrin coming there, and it will be strengthening your platelets plug. Is that clear?
Yes.
Yes, sir.
Okay, so who strengthens your platelets plug? Fibrin does that. Is that right?
Yes.
It means that secondary hemostasis is going to involve certain mechanisms in order to activate your fibrin, right?
Yes.
Okay. Okay. So, okay, another thing. Can you just tell me the two pathways involved in activation of your fibrin? You already know that. Okay, so for that, please raise your hand. Those who want to tell me, those who want to tell us the different pathway, extrinsic and intrinsic pathway, right? So, Dr. Lily, let's start with extrinsic pathway, right? In extrinsic pathway. Okay. Okay,
Uh,
before discussing extrinsic pathway, we know that in these pathways you have like certain factors which comes from your liver. We already know that, right? And they are basically released in an inactive form and they'll be converted into activated form, but the pathways for their activation is different, right? So let's discuss extrinsic pathway first. So, Dr. Lily, can you just please tell us that what leads to activation of extrinsic pathway? What's the main leading cause or what's the main leading factor activating your extrinsic pathway? Yes.
it starts from with factor 7.
Okay, trauma and a tissue factor, right?
Um,
Whenever we have trauma or tissue
yeah.
factor, it would activate your factor 7, right? Factor 7. What else happened then?
Then factor
Factor
8
7
and
is going to
9.
be in activated state, 7A, right? 7A. 7A. Okay, the main goal of both of your extrinsic and intrinsic pathway is to activate your factor 10 in the end, right? Like
Yes.
that's going to be the common activator factor of both of your pathways. So in extrinsic pathway, basically factor 7 does that. Okay, so can anyone just tell me how do intrinsic pathway activates your factor 10? Please raise your hands. Guys, I want you to participate in the session. It's going to be a long session. So okay, Dr. Shazail, can you just please tell us?
Yeah, it's subendothelial collagen that activates factor
Okay,
12 in an
perfect.
intrinsic
So
pathway.
perfect. So, subendothelial collagen or some negatively charged like structures, for example, subendothelial collagen. So, what would happen first? Your 12 is going to be activated, 12 converting into 12A, right? And we discussed just come backward, then what happens? 12A is going to activate your 11, right? Hello?
Right. Right.
Okay, 11 into 11A, right? Activated.
Yes.
We won't count 10 because 10 is the common one. So come back further. 9, right?
Yes.
Okay, so 9 is being converted into 9A. It's acting as a cofactor with factor 8, right?
That's right.
Yes, and factor 8 in turn is going to activate your factor 10. So what would factor 10 further do? It would just activate your prothrombin into thrombin, right? What would thrombin do? Thrombin would activate fibrinogen into fibrin. And in the end, you are having fibrin, which is going to help you strengthen your primary or plug or platelets plug. Is that clear?
Yes, it's clear.
We
Thank you.
already discussed. For example, if we have any problems with these factors with secondary homeostasis, so what would be the outcome? The clinical picture would be deep bleed, right?
Right.
Yes, we'll be discussing that. Okay, so can anyone just tell me the factors which are activated by your like coming out of your liver, activated by K plus something like that? Which factors comes from? Okay, doctor. Okay, okay, Dr. Sabira, can you just please tell us?
Factors 2, 7, 9, and 10.
Perfect. 2, 7, 9, 10. We are going to discuss that in a little bit detail just right after some while, right? Okay. Another point. Can you just tell me in order to check out or in order to see the activity of your extrinsic pathway? Like for example, in order to look for the activity of platelets, we use the term bleeding, right? Bleeding time. So what term do like suggest For example, monitoring the activity of extrinsic factor. What's the name of that?
Prothrombin
PT.
time.
Perfect. Prothrombin. And what about intrinsic factor?
PTT.
Okay.
Partial
APTT. Perfect. Activated partial thromboplastin. Okay. So let's discuss our next pathology, that is hemophilia A. You're going to see a lot of MCQs related to hemophilia A. What is hemophilia A? Okay. We already discussed how we are going to remember it. Don't call it hemophilia A. Call it hemophilia A. Right? Hello?
Yes, Dr. Right.
Yep, that's right.
Okay,
Yeah.
when we do not have 8, it means that you can't see activation of your fibrin, right? And whenever we have problems with secondary homeostasis, the main goal is fibrin. We already know that. So you are going to see deep bleeds, right? Deep bleedings, right? So whenever we have deficit factor 8, what would be the clinical picture? It would be deep bleeding, right? Hemarthrosis, bleeding into your joints. Is that clear? Post-surgical bleeding. Is that clear?
Yes.
Okay, let's discuss the lab findings, because we already know whenever we get MCQs from hematology, first of all, we are going to refer the lab values, right? So let's discuss some lab findings. So what would lab findings suggest? What happens to PT? It's your question. What's happened to PTT? What happens to bleeding time? Please raise your hands, those who want to answer, please. Dr. Mariam, can you just please tell us?
Yes, the PTT will be increased and
Okay,
the bleeding time will be normal.
okay, normal. And what about PT?
Uh, PT will also be normal.
Perfect, because PT have nothing to do with factor 8. You guys can see
Mhm.
here, right? Okay. What next? What would be the treatment? The treatment is so simple. Give them factor 8. Is it clear? Or
Yes.
recombinant factor 8. Okay, let's discuss another pathology, hemophilia B. What is, okay, just, turn this B, like that. So you're going to see a letter 9, right? Hello?
Yeah. Yep.
It means that in hemophilia B, we are going to see deficit or deficiency of factor 9. So what's the significance of factor 9? We discussed that you cannot activate factor 10 without both factor 9 and factor 8. We already know that, because factor 9 was acting as a cofactor. Is that clear? Hello?
Yes, Dr. Clear.
Yes,
But
yes.
okay, but do you guys just support my statement, which I'm going to tell you? If I do not have factor 9, it means that the problems which I'll be seeing in factor 9 deficiency would be same as that of hemophilia A. Can I say that?
Yes.
Because
Yes.
without the help of 9, you can't do the normal activity of factor 8. So all of the features are going to be resembling your hemophilia A.
Yes.
Hemophilia A, right? Okay, but how to fix that? Now giving factor 8 won't fix that. It just give them factor 9. Is that clear?
Yes.
Okay. So let's discuss, okay. Let's discuss our next pathology, that is von Willebrand disease. A lot of MCQs on von Willebrand disease, and I would say like a simpler topic as well, von Willebrand disease. Before discussing von Willebrand disease, you guys are going to tell me the normal function of von Willebrand factor. First of all, please raise your hands. We already discussed that. Dr. Daniela, can you just please tell us? Believe me, just do participate in these bootcamp session. Like you guys are already done. It's a kind of revision, right? Yes, Dr. Daniela, can you just please tell us what are von Willebrand factors?
Von Willebrand factor is needed to attach platelets to like sites of
Okay, perfect. What's the surface marker for that?
what's
The
not sure.
surface receptor, the surface receptor.
Glycoprotein
Oh, the GP1B.
1B, perfect. That's perfect, right?
Okay.
So we already discussed, if you guys remember, von Willebrand factors are found in certain bodies within the endothelium. What's the name of that bodies? Weber palate bodies, right? Weber palate bodies, right? Hello?
Yes, Dr. Right.
Okay, so in the Weber palate bodies, basically we are going to see von Willebrand factors, but not alone. Von Willebrand factors are, bound to factor 8, right? right?
Yes.
In
Yes.
order to increase the half-life of factor 8, von Willebrand factor also does that, right? So, okay, let's just do some pharmacological kind. For example, if I want von Willebrand factors to be released of feeble palate bodies, what drug am I going to give them?
Desmopressin.
Okay, desmopressin. Can I say simply just give them antidiuretic hormone?
Yes.
Yes.
Because both of them are
Yes.
same things, right? Okay. So let's discuss von Willebrand disease. What happens in von Willebrand disease? The idea is so simple. You do not have von Willebrand factors. No von Willebrand factors. If we do not have von Willebrand factors, can I say that again? It's going to lead to a lot of problems. Again, mucosal bleeding because all of your primary homeostasis is disrupted. Is that clear? Hello? Okay, so
Yes.
again, the problems which will be arising are going to deal with some superficial problems, superficial bleeding, mucosal problems, petechia, purpura, right? So let's discuss some lab findings. Lab findings. What will happen in lab findings is that what happens to bleeding time? Yes,
Increase.
perfect. Bleeding time. What happens to PT and PTT?
Normal. Has nothing to do with it.
Normal, normal, perfect. Okay, so you have a U-word MCQ. Let's discuss something about that. Do you guys know what is wrist ossetin test?
Yes.
Yes, Dr. Huda, can you just please tell
Yeah.
us?
It is a test to determine if the patient is deficient with factor 8 or von Willebrand factor.
Okay, mainly for von Willebrand factors, right? The idea is really simple. For example, if I have, a precipitate of, let's suppose, platelets, right? If I have a precipitate or, a precipitate or a medium in which we have platelets plus von Willebrand factor. If I want these platelets and von Willebrand factors in order to be activated, what am I going to do? I'm going to put something. What's that? Restositine, right? Hello?
Yes, doctor. We are getting.
Yeah.
Restositine, right?
Mm-hmm.
So restositine is going to cause platelets aggregation, but whenever the von Willebrand factor is present, if we have presence of von Willebrand factors, if you just add restositine into this medium, you are going to see aggregation. If we do not have von Willebrand factors, you won't see any aggregation. So can I say that restositine directly can give me an idea whether I have von Willebrand factors or no? Yes or no? What do you guys think?
Yes.
Yes,
Yes.
doc.
So can I say that in a disease, von Willebrand factor disease, this restositine cannot induce aggregation?
Yes.
Perfect. That's perfect, right? So it was all about our von Willebrand disease, right? Let's discuss our next pathology, vitamin K deficiency. So important, so simple. We discussed it a lot of time. Vitamin K deficiency. We already know that doctor just told us that we have certain factors which comes from your liver, but in order to activate those factors, what happens? Vitamin K does that activation, right? So what would vitamin K do? Vitamin K would just come. Yes, what would it do? It would activate an enzyme,
Yeah,
epoxide
epoxidase. Yes, yes.
epoxide reductase. What epoxide reductase is going to do? It's going to activate the factors. Which factor? 2, 7, 9, 10, protein C and S. 2, 7,
9,
9,
10,
10, C and
E and
S. Is that
S.
clear?
Yep.
Hello? Okay,
Yes,
Yes.
doctor.
which drug can we give, for example, if I want anticoagulation? Which drugs do we need to inhibit
Warfarin.
hypercoagulation? Warfarin. Perfect. Warfarin. So let's discuss protein C and S. What are protein C and S? We know they are normal anticoagulant found. In order to,
Yes.
keep balance of the coagulation, you also need some anticoagulatory mechanism inside your body. What's the mechanism of action? They will just inhibit your factor 5 and which factor 7, right?
Yes.
Once they inhibit 5 and 7, in this way, it can cause anticoagulation, right? Hello?
Yeah.
Yes, doc.
That's right.
Okay, let's discuss one of your UWorld MCQ. For example, okay, we know that the half-life of CNS is, least, right? Hello?
Yes, doc.
Okay, so for example, if I have an individual, I just gave him warfarin. If the half-life of CNS is less, can I say that these factors are going to be the first one which wanes out, which are finished? Hello?
Yeah.
Yes.
Okay, if they went out or if they finished out, they're the first one. Why? Because of less half-life. So can I say that if I'm, knocking down my anticoagulation like factors or anticoagulatory mechanism inside my body, so there would be chances of extreme coagulation, right? I'm just disrupting the balance, right? Normally you have a balance, C and S and coagulation. If they are going down, the coagulation pathway is going to be, dominated, right?
Yes.
Yes, right.
And it would appear in a form of warfarin, skin necrosis. You word MCQ. Does you guys are you guys just able to recall that MCQ?
Yep.
Yeah.
Okay, perfect, right? So this was all about vitamin K. So let's discuss how can we have vitamin K deficiency. First of all, vitamin K, A, D, E, K, right? It is a fat soluble, right?
Yes.
So any problem which leads to fat malabsorption can lead to vitamin K deficiency, which in
Yes.
turn can lead to this problem. Can I say that?
Yes.
Okay. Another thing, how can we have, like, for example, pancreatitis? You have a U word MCQ on that if you guys remember, right? Hello?
Yes. Yes, doctor.
Okay. Liver failure can also do that. If in the first, even if we do not have enough factors, C, S2, 7, 9, 10, it can also cause this problem, right? Excessive coagulation. Is it clear? So let's
Yes.
discuss our next topic, that is DIC, disseminated intravascular coagulation. What's the next name for that? Use in your U word. What's the name for that? Consumptive
Coagulability.
coagulopathy, right?
Yes.
Because what happens in that, if it's called consumptive coagulopathy, it means every coagulation factor, like even your primary homeostasis and secondary, all of them are consumed, as the name indicate, consumptive coagulopathy, right?
Yes, doctor, right.
So what happens in DIC, both the factor, that is platelets plus your like the secondary homeostasis pathway, extrinsic and extrinsic, all of them are consumed. When all of them are consumed, how do they get consumed? Can it lead to MAHA?
Yes.
Okay. If it lead to MAHA, can it lead to schistocytes or helmet cells?
Yes,
Yes.
sir.
Yes.
Okay, we are going to see schistocytes and helmet cells. If even your platelets and fibrin are consuming, so let's just refer to some lab values, right? So what happens to platelets count, increase or decrease in DIC? What do you
Decrease.
guys think? Okay, so platelets count decrease. So if it decrease, what happens to bleeding time?
Increase.
Increase.
Increase. Perfect. Okay. If all of your factors are consuming as well, so can you just tell me what happened to PT and PTT?
Increase.
Increase.
Both of them are going to be increased because you're consuming all of the factors as well. Is that clear?
Yes.
What happens to D dimers? Yes, how can you forget?
Increase.
D
Increase.
dimers are going to be increased because D dimers are basically the split product of fibrins, right? If you have excessive fibrin activity, it means that what happens? Will
The
be
dimer will
consumed as
increase.
well.
Yeah.
Yes, fibrinolysis, right? The plasmin, plasminogen, which we are going to discuss right after this topic, right? Okay, so next question arises that in which, okay, as you guys know, what would be the keyword used for in your U word MCQ? Excessive bleeding from your catheter sites,
Yes, sir.
remember?
Yes, sir. Yes.
Okay, perfect. So, how can we get DIC? The first one is obstetric complication. You have a U word MCQ, right? So, what happened in obstetric complication? For example, whenever the amniotic fluid come out, it have tissue factor. It can activate both of your pathways, right? So, it can cause DIC. Is that clear? You have a U word MCQ on that.
Yes.
Hello?
Yes.
If someone is having sepsis, sepsis can induce a lot of damage. A lot of damage can induce a lot of like primary and secondary hemostasis to be activated all at once, causing DIC. What else? Or rods. How can you forget that? You will MCQ from WBC. Anyone who can just tell me?
Yeah.
Or
Yeah.
rods can also cause DIC, right? The
Yes.
myeloperoxidase, right? The
Yes.
precipitated or crystal form of myeloperoxidase can also do that, right? So let's discuss our next topic, disorder of fibrinolysis, right? So can you just tell me the pathway? How do we have like a mechanism that is known as fibrinolysis? Like what is plasminogen, plasmin? Can anyone just tell me?
Come again, sir?
Normal.
Doctor,
Okay.
plasminogen, it is synthesized from the liver, okay, and
Okay.
via tissue plasminogen activator, it is converted into plasmin, and this plasmin it furthermore degrades fibrin into fibrin products like D dimer.
Okay, perfect. So normally inside our body, for example, if you have certain processes in which we are going to see a lot of, thrombin, thrombosis. So in our body, we have, a counter regulatory mechanism for that as well. What's that is? Plasmin. So normally plasminogen comes from your liver. Tissue plasmin activator can activate plasminogen, convert it into plasmin. What plasmin does in future? It would just, like cause fibrinolysis. It would just try to break your fibrin products, right? So that's all. Just keep it in mind. Giving you a lot of D dimers. Is that clear?
Yes,
Hello?
sir.
Okay, so let's discuss our next topic, that is thrombosis. Right. So you have like thousands tons of MCQ on thrombosis. I think it's the easiest topic now which we are discussing. You already did like hard topics. So what is thrombus? We know thrombus is a clot, right? Can I say that?
Yes.
Yes, you
Okay.
can.
We can have thrombus everywhere, right? But there are certain mechanism, or there are certain things which should be satisfied in order to call like something a thrombus, right? And what's that? We already discussed that in order to call something a thrombus, right? In order to like cause a clot, you can have clot, you can have thrombus, right? But in order to call it thrombus, you should satisfy these two criteria. What were those criteria? It should be attached to the wall, right? Hello?
Yes.
And
Yeah.
second criteria, it should be having certain lines which are known as lines of Zane, right?
Right.
What are line of Zanes? You already know that. They are basically, yes. What are line of Zanes?
These are alternating layers of platelets and fibrin plus
Oh,
RBC.
perfect. So what happens that, for example, if you have a blood vessel, let's suppose if I'm having a thrombus there, right? So the first criteria in order to call this thrombus, it should be attached there, right? And the second criteria, if you just zoom in the picture, you'll be seeing alternating lines of platelets, fibrin, platelets, and red blood cell. Fibrin, platelets, and red blood cell. Then you can call it a thrombus. Is that clear?
Yes,
Yes.
sir. This
Okay.
is how we distinguish between the thrombus before death and after death, right?
Yes, that's perfect. Like postmortem findings, like these are the features to distinguish thrombus from postmortem clot, right? From the clot, here we discuss you can have clot and thrombus. Is that clear?
Yes, sir.
Okay, so let's discuss that what things can lead to thrombus. So for that we have a triad, Virchow triad, if you guys remember, right? So we need three things in order to be satisfied to have thrombus formation. First of that was immobilization, right? And endothelial damage. What else? The last one?
Hypercoagulable.
Mm.
Hypercoagulable state. Is that right? So, how can immobilization lead to thrombus formation? We have discussed it a lot of time, right? For example, we discuss what happens in AFib. Your atria cannot contract. If the atria cannot contract, it means that you cannot, like, you're going to see stasis, right? And whenever we have stasis, what happens? All of the coagulation factors aggregate, they precipitate. Once they precipitate, it can lead to activation of your coagulation pathway. Is that clear? Which can lead, in turn lead to thrombus. Is that clear?
Yes.
Yeah.
Embolization. An example for, okay, deep vein thrombosis. For example, if you have an individual, he have a big journey, a big flight, and he was like immobilized for a quite duration of time. That can also lead to DVT. We already knew that, right?
Yes.
Endothelial damage can also do that. How can we have endothelial damage? We already discussed. There are a lot of mechanisms which can cause endothelial damage. Like normally, we know we have certain protectory mechanisms in order to avoid thrombus. What's that? Yes,
Injury.
heparin-like molecules, right? Prostacyclins. Remember? So whenever these mechanisms are disrupted, it can lead to damage of your endothelium, right? For example, overactivation of your plasmin can also do that, right? Hello?
Yes,
Yes.
Dr.
Yes.
And the
Yes.
other thing which we discussed,
Judy.
if you guys remember homocysteine, you should be knowing the pathway of homocysteine, right? We remember we are going to discuss it in macrocytic anemia as well, right? So what happens? We have tetrahydrofolate bind to methyl. Remember, methyl is going to give methyl to your B12. B12 is going to take this methyl, and this tetrahydrofolate is going to participate in DNA synthesis, right? Simple. Is that clear? And B12 further is gonna give this methyl to homocysteine. Is that clear? And homocysteine is gonna be converted into, once it take its methyl, it's going to be converted into methionine, because homocysteine buildup isn't good. It's toxic. It can lead to damage of your endothelial cells, which in turn can lead to thrombosis. Is that clear?
Yes, doctor.
Okay. So, for example, if you do not have tetrahydrofolate again, we are going to see a lot of homocysteine accumulation. If you do not have B12 again, we are going to see a lot of accumulation of homocysteine. So, can I say that B12 deficiency or folate deficiency can cause thrombosis? Can I say that?
Yes.
Perfect, perfect, right? What are some other causes of thrombosis? Hypercoagulable state. How can we have hypercoagulable state? The most important and classical for your steps, oral contraceptive use. It can cause hypercoagulable state, right? You got MCQ on that.
Yes.
Hello? Okay,
Yes.
so OCPs, oral contraceptive pills, can cause hypercoagulable state. Another thing, what else can cause? Protein C and S deficiency. Remember, if you are just knocking off your normal anticoagulatory mechanism, that was protein C and S. Again, you are going to see, the balance is going to shift towards coagulation. More coagulation can lead to thrombosis. Is that clear?
Yes.
Okay. So what was the mechanism of protein C and S? We already discussed. They're gonna inhibit your factor 5 and factor 7. For example, if I have certain mutation in factor 5 lead a mutation, it means that now factor C and S cannot inhibit your factor 5. If it cannot inhibit your factor 5, so can I say again it would increase the risk of thrombosis?
Yes.
Sorry,
Okay.
Dr. Ahmed, sorry, is that factor 5 and 7 or factor 5 and 8 you do?
Sometimes, it happens. Sorry for that. Okay. You guys are gonna correct me, right? It's 5 or oh, it's 8. It's not 7. It's 8.
You wrote it right, but you say it wrong.
Like I'm just more focused on the concepts this time, right?
Yeah.
I'm just doing some mistake with writing some things down, or so just sorry for that. You guys please correct me. Is that clear? I'm more focused on the concept, right? So if we have problems with factor 5 and 7, can it lead to thrombosis? Yes or no?
Yes.
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 Why? Because the normal anticoagulatory pathway or mechanism is disrupted now. Is that clear?
Yes.
Okay. For example, if someone develops thrombus, deep vein thrombus, right? So what's the next thing which we should just keep in mind? This thrombus can dislodge. It can emboli, right? You can have emboli.
Right.
You can have embolism. For example, if we have DVT, let's discuss some of the concept of cardiovascular as well, right? So my question for you as your cardiovascular CVS module question, we have an individual, he's having ASD. First of all, you are going to tell me which heart sound is associated with ASD. What's specific for ASD? Hello?
S2 splitting.
S2 splitting. Is it a fixed split or a wide split?
Wide fixed split.
Wide.
Wide fixed split.
It's
Wide fixed split
yeah,
of
fixed split.
S2. Perfect. Okay. For example, if I just do, have an individual with this pathology, he's having ASD, his DVT, his thrombus dislodges. What else can happen? He can have an emboli. What's the name of that emboli? Starting with something P.
Paradoxical emboli.
Paradoxic emboli,
That's
yeah.
that's perfect. Paradoxical emboli. What, for example, if I have a paradoxical emboli, what's the main idea of paradoxical emboli? If the right-sided embolus move to the left-sided, it can cause stroke, cryptogenic stroke, right? It can cause. Dr. Shafiq,
Yes.
can you just please fix your
Yes.
mic? You have some, okay. It can cause stroke. It can cause renal infarction. It can cause GI infarction, ischemia, right?
Yes.
Okay,
Yes.
perfect. DVT, right? So we can have like embolus not only of the thrombus, we can have emboli of a lot of things. We discussed that. We can have a gas emboli. So Dr. Daniela is going to give her some of the example of gas emboli in the story which we discussed for deep divers, coming back to the land and everything, please.
Sorry, could you come again with the question? I didn't hear you.
Okay, so
Then
my question for you is we can have emboli of different things, not only the thrombus or blood clots, right? We can have emboli of gas embolus as well. So I want you to elaborate a little bit about gas emboli and the conditions and situations associated with gas. How can someone have gas embolus?
Mm. I'm not sure of this. Sorry.
By diving, rapid ascending from
Ascend.
diving.
Okay, let's just start with some common things. For example, if you have an individual, he's having laparoscopic surgery for which we distend the abdomen with gas further, right? We're doing
Yep.
procedure. This gas can enter into your blood vessels. It can cause embolus, gas embolus, right? And we discussed nitrogen embolus. For example, if we have deep divers, they are approaching fast. If they have rapid ascent towards the surface of water, what happens? All of the nitrogen gas is going to precipitate into your blood, which can cause emboli. What's emboli? It's, simply you can just remember of emboli as ambulance, right? Ambulance keep on moving on roads, right? So it keep on moving. Anything, any thrombus which keep on moving is ambulance. It can move everywhere, right? It have the right. It have open roads, open blood vessels, right? It can stick anywhere. Is that clear?
Yes, doc.
Okay. We can also have some fat ambular. You are going to see an MCQ in MSK module, which is our upcoming module. Can you just give me some of example of fat ambulance? What is fat
When
ambulance?
yes, when there is trauma to like your femoral bone or something,
Perfect.
big
Femoral
bones.
bone, pelvic bone, right? So what the bone marrow can go, it can ambulate, it can keep on moving here and there in your blood vessel. It can cause problems, right? Okay, so the last topic for today's discussion, and with that, we have ended our platelets module, is pulmonary embolism. So simpler topic, we have discussed it a lot of times. So I want Dr. Shafiq to please tell us something about pulmonary embolism, and then we are gonna have 10 minutes of break, and we'll be starting our red blood cell module. Yes, Dr. Shafiq. Can you just please tell us something about pulmonary embolism? What is pulmonary embolism?
Pulmonary embolism is ambulance that happen in the pulmonary arteries, and
Okay, perfect. If we have an emboli DVT, right? A normal individual, no with no ASD, it can just go to your right heart, the right atrium, right ventricle, pulmonary vessel. It can dislodge in, small vessels. It can give us a VQ mismatch, and that resemble a dead space. Can I say that? Zero
yes,
perfusion with a lot of ventilation, right?
yes,
Hello. So you are going to see a lot of other symptoms as well. What would be the symptoms? Pulmonary infarction. It can give you pulmonary infarction, right? PQ
yep,
mismatch, already discussed. It can give us like, hemoptysis, pleuritic chest pain, infection there, and pleural effusion. Is that clear? And it can lead to even death, right?
yep.
Yes. For example, if you have, an embolus there in your blood vessel. Okay, let me just ask you a question, right? Something related to your cardiology. As you know, it's a revision session. For example, if let's suppose if we have an embolus in your pulmonary, okay, these are your pulmonary vessels, right? This is your pulmonary, big pulmonary vessels and small vessels coming out of that. So, for example, if I have pulmonary embolism, what happens to afterload on right ventricle?
Increase.
After load increase.
Increase. Perfect. So, can I say that the resistance to right heart can also increase, right?
Yes,
Okay, okay. Apart from pulmonary embolism, whenever the resistance to right heart increase, it would lead to a phenomena called pulmonary. Remembered?
yep,
Yes, and if you guys remember, obstructive sleep apnea also does that. If you remember, hypoxia, vasoconstriction, right-sided overload, and right-sided heart failure, called pulmonary. It was apart from this topic. Is that clear?
yes.
Okay. So hope so you guys enjoyed the platelets module. So let's have 10 minutes of break.
Yeah,
Uh,
can we recap?
Can I ask a
Can we
question,
recap,
please?
doctor? Can
No,
we
can I
recap?
ask, sorry,
Can
can
you
I ask
ask
a
somebody
question,
to
please?
recap for us?
yes, yes,
Please,
yes,
can I ask a
yes,
question?
yes, Dr. Daniela, please.
Please, could you just reiterate? Could you just explain again what you said about the warfarin skin necrosis, please?
Okay, no problem.
Thank you.
Okay.
Thank you.
Will be okay. Right after 10 minutes of break, I'll just revise each and everything. Then we'll move. Right. I also need a break sometime, guys. Okay. So for
Mm-hmm.
warfarin necrosis, we discussed that what warfarin do, it inhibit epoxide reductase. Is that clear?
Yes. Okay.
Okay. If it inhibit epoxide reductase, it means the level of all of these factors are gonna go down, right?
Yes. Yes.
But the half life of CNS is very low. So CNS are the first factor which will be slowed down, right? That like these factors are gonna go down slowly, but they will just go down so fast because already they have less half life, right?
Mm-hmm. Okay.
So like you can just think of like that factor like 2 is going down, 7 is going down, 9 is going down with same speed, but CNS goes down like that, and they are anticoagulant, right? Hello.
Yes, I can hear you. Mm-hmm.
So if you are just like your anticoagulants are going down abruptly, so this the coagulation can over exceed, it can dominate.
Okay.
Are you just getting me? If
Yes, I
CNS are
am.
going down,
Yes.
if your
See.
anticoagulatory mechanisms are going down abruptly, so still you have certain factors which can cause coagulation. Coagulation how? In a form of warfarin skin necrosis. This
Okay.
coagulation can lead to necrosis of your skin. Is that clear?
Okay. Thank you very much. Mm-hmm.
Okay. Okay, so let's have 10 minutes of break. I'll be revising this entire module again. Then we are going to shift to red blood cell. Thank you so much. Stay here.
Thank you, Doc. Thank you.
I'll be
Appreciate
back
it.
in 10 minutes. Hello, can you guys hear me? Hello? 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 Hello?
Yes.
Okay.
Yes, sir.
Okay, so for Dr. Shafiq, just he wanted a quick revision. So let me just recap it. So just bear me again, right? So we have two processes, primary hemostasis, secondary hemostasis. Primary hemostasis, platelets are gonna come. Secondary hemostasis, strengthening of the platelets plug. Is that clear, Dr. Shafiq?
Yes, clear.
Okay. Primary hemostasis, the first step, endothelin, vasoconstriction, then attachment of platelets. But we want things, von Willebrand factor, GP1B, attachment of platelets to von Willebrand factor. If you have genetic deficiency, Bernard Solier. Platelets to platelets aggregation, we need ADP, we need certain chemical mediators like thromboxane A2. Which receptor? GP2B3A. If it is deficient, Glanzmann's thrombasthenia, right?
Okay.
Primary hemostasis, superficial bleed, mucosal bleed. Secondary, deep bleed, right? Normal range, 15K to 40K. Immune thrombocytopenic purpura and immunity, autoimmunity causing death of your platelets. How? Spleen make those autoantibodies and kill these platelets as well. In order to avoid, remove the spleen or distract the spleen with IVIG, decrease platelets. No impact on PT and PTT. MAHA, microangiopathic hemolytic anemia, a lot of mesh work, which just tear off your red blood cells, make them schistocytes or helmet cells, right? TTP,
Oh,
thrombotic thrombocytopenic purpura, right? What happens in thrombotic thrombocytopenic purpura? Yes, thrombotic,
that is,
it means we are going to see thrombus, thrombocytopenia, less platelets leading to purpura, right? How?
yes.
ADAMTS13 not present, big multimer causing overactivation of platelets, again causing MAHA. HUS, hemolytic uremic syndrome. What? Shiga-like toxin, verotoxin, causing excessive damage. Excessive damage leads to, hello? Excessive damage leads to
Yeah, thrombosis.
overactivation again, right?
Yes.
Overactivation.
More platelets come in there, more platelet causes the mesh causes, the schistocytes.
Okay, perfect, right? So we were discussing extrinsic and intrinsic pathway. Factors are tissue trauma, factor 7, factor 10 activation. And PT in order to look for the activity. Intrinsic 12, 11, 9, 8, right? Hemophilia
Yes.
A, no 8, deep bleed. Lab findings, increased PTT, nothing else. Hemophilia B, factor 9 deficiency, right? Same as hemophilia A, but not be treated with factor 8, treated with factor 9. Von Willebrand factor disease, less von Willebrand factor. Again, bleeding time increase. Give desmopressin, LDH. Restorative test is going to be negative. Vitamin K deficiency, we already discussed it, right? 2,
Yes.
7, 9, 10 goes down. CNS less half-life. Give warfarins. Warfarins can necrosis. Perfect. DIC, consumptive coagulopathy, right? So we have a lot of platelets consumed, a lot of factors consumed, all of the bleeding time increase, PT increase, PDT increase, D dimers increase, right? Obstetric
Yes.
complication can do that. It can activate plasminogen. Okay, plasminogen into plasmin, normal pathway. If it exaggeratedly activated, it can also cause thrombosis. Vein line attachment to blood vessel. Three things, Virchow triad. Immobilization, endothelial damage, hypercoagulable state. Immobilization, example is AFib,
Ye-
right? Tetrahydrofolate, B12, homocysteine. No tetrahydrofolate, a lot of homocysteine causing damage. One of the criteria of Virchow triad, satisfied, cause thrombosis. Thrombosis can emboli, like an embolus, right? If you have ASD, it can lead to paradoxical emboli. That's all.
Okay, thank you, Doc.
Okay, perfect. So let's discuss our red blood cell module, right? Red blood cell module. So the first thing which we are going to discuss is anemia. What happens in anemia? What are the clinical features? We know what is anemia whenever we have less red blood cells. It's going to lead to anemia. Presenting feature, if less red blood cell, it means oxygen delivery is compromised. It means we are going to see pallor, we are going to see angina. If we already have some problems with coronary artery due to oxygen supply demand mismatch. We already did that, remember?
Yes.
Okay. So how do we classify anemias? We have three criteria for that, right?
Yes.
Microcytic, macrocytic, and normocytic. For the microcytic, we discussed that we use a term MCV, mean corpuscular volume. Whenever it's less than 80, it's microcytic. Okay, 80 to 100 is normal, right? Less than
Yes.
80 microcytic, more than 100 macro, big, right?
Yes.
More than 100. And normocytic, normal. We discussed how can one have microcytic anemia. We discussed that we have red blood cells. In the red blood cells, we have hemoglobin. Hemoglobin is made of heme plus globin. Heme
Yes.
further is made of iron plus porphyrins. And globin is made, you have two chains, alpha and beta globin, right? So anything which leads to problem in formation of hemoglobin would lead to less hemoglobin within the red blood cell. In order to compensate for that, your red blood cell is gonna do an extra division. And extra division is going to lead to microcytic anemia. Remember?
Yes.
So what would be the cause of microcytic anemia? The idea is really simple. If we have less iron, it means we have less hemoglobin, red blood cells doing extra division, leading to microcytic
Yes.
anemia, right? So iron deficiency can be one of the cause, iron deficiency. If we have appropriate iron, but the iron isn't participating in formation of hemoglobin, anemia of chronic disease, remember?
Yes.
Anemia of chronic disease can do that. If you have problems with protoporphyrin or porphyrins, what's that? Again, you will be having less hemoglobin in red blood cell, extra division, microcytic anemia, and the problem sideroblastic anemia, right?
Yes.
Remember, we're going to discuss that. And problems with alpha and beta, thalassemia. It can also lead to
Yes.
microcytic anemia. Perfect. Let's discuss iron deficiency anemia in a little bit more detail. How do we absorb iron? We know. Iron
Yes.
is reabsorbed in where? Duodenum, right?
Yes.
By a transporter that is known as ferroportin, DMT1 ferroportin. It would just transfer the iron where? To your cars. Remember those cars were transferrin, right?
Yes.
Transferrin would just take this iron to a factory. What was a factory? Ferritin, right?
Yes.
Ferritin were present in macrophages plus liver, right?
Yep.
Okay. So we discussed that whenever the ferritin stores go down, the transferrin or the carbs would increase because it would tell all of the transferrin, it would tell liver to give me more transferrin so that I can have a lot of workers of iron, right? So we discussed whenever ferritin goes down, transferrin goes increase. Whenever ferritin increases, transferrin goes down. You already know that, right?
Yep.
Okay, so we discuss another term that is total iron binding capacity. What is total iron binding capacity? Total iron binding capacity, as the name indicates. Where do iron bind? To transferrin, right? So the number of transferrin basically refers to the IBC. The number of cars, right?
Yes.
Okay, so they are going to be the number of transferrin. We also discussed that normally not all of the cars are occupied by iron. Or if you have 10 cars, 3 of them are going to be occupied by iron. So normal the percentage of saturation of these cars or percentage of saturation of transferrin normally is 33%, right?
Okay.
Remember?
Yes,
Hello?
doc.
Okay, so how can one have iron deficiency anemia? You have a UWorld MCQ. Infants. Because infants cannot consume a lot of iron. They are breast, for example, if you have a breastfeeding infant, so human milk is less with iron, right?
Yep.
If we have a lady, she is having a lot of menorrhagia, excessive bleeding in her like periods or cycles, it can also lead to loss of iron in the hemoglobin in the red blood cells, which can lead to.
Yes.
Okay, perfect. We also discussed that we have certain worms, Americans, Necator Americans, and Calostoma udinale, right? They can
Yes.
also consume all of the red blood cells. They can suck all of the blood, which can lead to iron deficiency anemia. Is that clear?
Yes.
Gastrectomy. What happens in gastrectomy? If someone is having gastrectomy, what happens? The acid is lost, right? No acid. And remember, this acid basically keep the iron in Fe+2 state, right? So
Yeah.
if someone is having gastrectomy, he won't be having acids. No acid, so the iron cannot be remained in Fe+2. It would be in Fe+3, and we know methemoglobinemia. Fe+3 cannot bind to oxygen. Again, we are going to see, yes, less hemoglobin, right?
Yep.
Iron deficiency, perfect. So let's discuss some stages of iron deficiency anemia. Whenever the stores are depleted, whenever we have less ferritin, what happens to transferrin? We already discussed that.
Increase.
Increase.
Transferrin increases. Perfect. Right? Okay, so first of all, transferrin would increase, and if the serum iron is depleted, so what happens? The saturation is also depleted if you have less iron intake, right?
Yeah.
Okay. So what would be the clinical features? We discussed that you are going to see a condition pica as well. Okay, what is pica?
He will eat anything. Like
Yes, he will eat non-nutritious thing, like he will just eat soil, or he will just chew on the ice, right? So the idea for that is that if he is deficit with iron, he would just do some abnormal acts, and he would be just thinking of that whether I can just take iron from that, right? So this is a condition known as pica, in which an individual is basically eating non-nutritious things, for example soil, right?
yep.
Okay, perfect. So let's discuss our next pathology, anemia of chronic disease. Anemia of chronic disease. What happens in anemia of chronic disease? We already discussed. First of all, we are going to see a chronic disease, right? And what this
Yes.
chronic disease is going to do, it's going to release, acute phase reactants from your liver, right? So acute
Face
phase
reactants.
reactants. What happens? Acute phase reactant, one of the acute phase reactant is hepcidin, right?
Hepcidin.
What hepcidin is going to do, it's going to tell the factory or the stores to not release the iron, don't bring out iron. Why? Because in
Because
chronic inflammation, the bugs or the bacteria survive on this iron. So it's one of an adaptatory or a good mechanism for our body. But what's the what's the bad side of this? That if your ferritin aren't releasing iron, it means this iron cannot be participated in formation of hemoglobin. So less hemoglobin. If we have less hemoglobin, again, red blood cell is gonna do an extra division. Is that clear?
yeah.
Which leads to microcytic anemia. Is that clear?
Yep. Extra division. Yeah.
Okay. So let's discuss some of the lab findings, right? In this pathology. So you guys are going to tell me the lab findings. So those who want to participate, please raise your hands. Dr. Rebecca, can you just please tell us what will happen to the level of ferritin if I'm just not, okay, what will happen to ferritin? Ferritin stores?
Yeah, it will decrease. It will be low or normal.
Hmm.
It
And
will
If
then
I'm not allowing
will be
iron
low.
to come out of the stores, if I'm not,
Increase,
Will be low.
increase.
okay,
Increase.
Dr. Rebecca, listen, if I'm not allowing the iron to come out of the ferritin, so I think the ferritin stores would be so high
Yes, yes. Sorry,
because
iron.
the hepcidin isn't allowing them to come out. So ferritin increase. Whenever the
Yes,
ferritin increase, you should know what happens to TIBC, or the number of cars that would decrease,
yes.
right?
Low or normal. Yes.
And less saturation as well, because you have less iron. So now 1 or 2 cars are going to have iron, right? 33% percentage saturation is also going to be decreased. Is that
Mhm.
clear?
Yes. And then hepcidin will be increased.
Yes, perfect.
Low,
Hepcidin is gonna
low increased. Then
increase.
low,
Perfect, right?
low
So
side. Yeah.
yes, so let's discuss our next pathology, that is sideroblastic anemia. Sideroblastic anemia. So for that, we discuss what happens in sideroblastic anemia. The porphyrin or protoporphyrin aren't synthesizing well. You do not have enough protoporphyrin. So in order to look the details of this pathology, first of all, we should know the normal formation of porphyrin or protoporphyrin. How does protoporphyrin even come to existence? So we know we have, yes, succinyl coenzyme A, right? It's going to be converted into an intermediate which is known as ALA, right? ALA, aminolevulinic acid, right? By using two things as a cofactor, B6 and ALA
ALA synthase.
synthase. Perfect. Then ALA further is going to be converted into ALA. Yes. Hello?
Yep.
Porphobilinogen. It's gonna convert
Yes, porphobilinogen.
Oh,
No, that was an enzyme, ALAD, right?
it. Yes.
yeah, decarboxylase.
Porphobilinogen. And porphobilinogen further is going to be converted into
European
protoporphyrin. So
photo.
can I say that if I have any deficiency of these two enzymes, it can lead to less protoporphyrin?
Yep.
Right?
Yes.
Yes,
If
sir.
I have less protoporphyrin, can I say that hemoglobin is going to be less?
Yes.
If hemoglobin is less, can I say that you are going to see an extra division or microcytic anemia?
Yes.
Right? And then you have an enzyme that is known as ferrochelatase, which basically attaches iron to your protoporphyrin, right?
Yes.
So if okay, all of this mechanism happens in mitochondria, right?
Yep.
For
Yes.
example, if I have no or less or even absent protoporphyrin, so still iron is gonna come to my mitochondria, but iron won't form anyone to bind to them, right?
Yes.
So what happens? Iron is gonna accumulate in the
Mitochondria.
mitochondria, right? And this mitochondria in turn would surround your nucleus. So whenever you have a
Yes.
lot of iron within the mitochondria, which is surrounding the nucleus, it would just give me a ring form structure, which is known as sideroblast. Sidrin stands for iron and blast within the cell. So let me call this anemia as sideroblastic anemia. Hello?
Yes, doc.
Okay. Is that clear?
Yep.
Okay. So let's discuss some lab findings as well. What will we see on lab findings? We have normal iron, right? But the problem is with protoporphyrin.
Yes.
Okay. If we have like problem with protoporphyrin, so what happens to ferritin store? If you have sufficient amount of iron, it would increase. What happens to TIBC? It would go down. We already know that. Hello?
Yes.
But what happened to serum iron? Serum iron would increase. Saturation would also increase because you have sufficient amount of iron. Is that clear?
Yes, doc.
Okay. So I want someone to revise this pathology for me. So please raise your hand. Anyone else? Okay, Dr. Muskan. Can you just please tell us something about sideroblastic? Why do we call this sideroblastic anemia? Why do you call this condition sideroblastic anemia?
Because it forms a hydroblast ring structure.
Okay, how do we have that?
Okay, so the mechanism for this is that we knows okay succinyl CoA, okay, via
Okay.
ALA synthase and B6 cofactor. It forms ALA, aminolevulinic acid, okay?
Okay,
That's
what
why
cofactors and enzymes are required for that?
ALA synthase and B6, vitamin
Okay.
B6, okay?
Okay. Yes.
After that, ALA will be formed, aminolevulinic acid. After that, what happens? It converts into this one, porphobilinogen. Yes, porphobilinogen via ALAD. Okay, that
Okay.
is, yes, that is aminolevulinic acid dehydratase. After
Okay.
that, it converts into protoporphyrin, and after that into iron via the ferrochelatase. So this ferrochelatase, it attaches the iron to protoporphyrin. Yes.
Okay. For example, if we have problems with this enzyme, it can be genetic, it can be acquired. What are
Yes.
the acquired causes of problems? Yes.
For
Lead poisoning. Remember?
yes, yes, and deficiency of vitamin B6, it can also
How
lead
do
to
we
this.
have B6 deficiency? Which medication is associated with that? Very high yield.
Isoniazid.
Okay, perfect. Treatment of TB, tuberculosis. It can also knock down your B6, vitamin B6, which can lead to this condition. Is that clear?
Yes.
Alcoholism, mitochondrial toxin.
Yes.
Okay, perfect. So let's just come to thalassemias now, right? Okay, thalassemia. So what is thalassemia? We already discussed. If we have problems with globin chains, right? So when the globin chains go down, the idea is very simple. Hemoglobin goes down. The hemoglobins go down. Again, we have an extra division of red blood cells leading to microcytic anemia. But we can have, we already know we have alpha globin chains and beta globin chains, right?
Yes,
So
Prof.
either we can have problems of alpha or beta. So let's discuss problems with alpha and problems of beta, right?
Yes.
So for alpha, we already discussed we have 4 genes which are basically present on chromosome number. Which chromosome?
16.
8.
Okay, 16. We
Okay.
have 4 genes, right? Right? 2 on each chromosome. For example, okay, and this pathology or this problem with alpha globin can is due to deletion, right? We already know that. And problem with beta globulin is due to mutation, right?
Yes,
Hello?
right.
Okay, so for example, if one of the gene is deleted, so what would we see?
Asymptomatic.
Yes, this individual will be asymptomatic because one gene deletion has no significance. You have a U word MCQs on that, the percentage one, if you guys remember. What else? For example, if 2 of them are deleted, right? So we can have 2 variants of that. Either the 2 of them can be deleted on same chromosome or one on one chromosome and other on
Yes.
the other chromosome. So that is whenever deleted on the same chromosome, that's known as
Cis.
deletion.
Yes.
Whenever deleted on the other,
Trans.
transdeletion. Cis is, you know, bad for offspring. You have a you word
Yes.
MC on that, right? Because if the offspring get both of this, you know, a single chromosome, both of the defective or bad genes, there is increased chances of having alpha thalassemia. Is that clear?
Yes. Yes.
But if all of them are deleted, what happens? You have remaining gamma globulins, right, in the fetus. They can aggregate, they can just form a hemoglobin BART. BART, that was BART, right?
Yes.
That, okay, that was BART or hemoglobin H?
But yes, right.
But this
Okay,
is when all the 4 deleted, isn't it? Yep.
sorry.
Yeah, parts when all the 4 deleted or
Perfect. So that's going to be hemoglobin BART, which is toxic to your red blood cells. It can cause anemia, right?
yes.
Okay. Let's discuss beta thalassemia. For the beta thalassemia, we discussed it's going to be okay. Which chromosome number for beta thalassemia?
11.
11. How much genes do we have for that?
2.
2. Is it due to deletion or mutation?
Mutations.
Mutation. Mutation can be like normal, like a moderate or severe, right? So in case
Yes.
of moderate,
Yes.
what are we going to see? We are going to see beta chains, but less in number. And in severe form, we are going to see no beta chains. That's obvious, right?
Yes.
So we discussed 2 variants of that. Either we can have absent B or either we can have B but less in number, right? So for example, if one individual is having like normal B and with a less B, so it will be almost asymptomatic, right?
Yes.
Okay. For example, if a person is having at the same time B naught, B naught, so it would be highly symptomatic, right?
Yes.
Thalassemia major, right?
Yes.
Okay.
Yes.
Okay. So besides that, if a person is having thalassemia, right, he's going to have extramedullary hematopoiesis. What do we mean by extramedullary hematopoiesis? What would be the characteristic findings on X-ray? We discussed. So,
Splenomegaly.
okay, so please raise your hands, those who want to. Okay, Dr. Shafiq, can you just please tell me why do we felt a need of extramedullary or hematopoiesis outside of your medulla or your bone marrow? Why do we felt need for that?
Because we the body think that we need to produce more red blood cells.
Okay. Okay, so
Uh,
what would it do? It would just tell the skull to make red blood
yeah,
cell.
more.
It would just tell your faces or your facial bones to make red blood cell. It would just tell your
Yes.
spleen and liver, right?
Yep.
So we are gonna see, okay, if the skulls of crew cut appearance, right?
Yes. Coreo cut
For
appearance.
the facial chipmunk faces.
Chipmunk. Yes. Faces.
For the spleens, splenomegaly.
Yes.
Okay, and for the liver, hepatomegaly, right?
Hepatomegaly.
Okay, that's perfect. So we are going to see these things. That was all for microcytic anemia. So before someone asks me to do a revision, so I want to volunteer some of the people, like anyone who can just give us an overview of entire microcytic anemia. So Dr. Ramesh is going to do that for us.
Mm.
Okay, doctor.
Okay, Dr. Ramesh, can you just please start
Um,
from the microcytic anemia, its causes and everything? Can you just have an overview for us?
Okay, so microcytic so for microcytic anemia, the mean corpuscular volume is should be less than 80, so that will be called as microcytic.
Why do
Now
we have that?
yeah, so when there is decreased hemoglobin production, then RBCs will go and will undergo an extra division to compensate, and that will cause decrease the volume.
Okay. How
Yeah.
can we have that?
Okay, so for underproduction of hemoglobin, we need to look at the constituents. So hemoglobin is made up of heme and globin. Heme is made up of iron and protoporphyrin rings, and globin is made up of alpha and beta chains. So any defect in all those components can give rise to macrocytic anemia. Okay, now like talking about iron, so we can have iron deficiency anemia.
Hello,
Now it
we
can
can't
be.
hear you, Dr. Abiz. Hello? Hello? Can you guys hear me?
Yes,
Yes,
doc, we
sir.
can hear you.
Okay, so anyone, I think Dr. Amis is, hello, Dr.
Hello.
Amis, can you hear us? Yes, please. Can
Yes,
you
can you hear me now?
Yes, I can hear you. Please continue.
Okay, okay, yeah, my question. I got some network issues. Yeah, so decreased. So iron deficiency, it can be of two types. Either there is decreased iron intake, and or it can be like the iron is sequestered in the macrophages and it is not coming into the circulation, which we see in anemia of chronic disease. Okay,
Okay,
and now we can also have the defects in protoporphyrin ring synthesis, and that is called sideroblastic anemia. And also we can have defect in alpha and beta globin chains production, and that is thalassemia.
okay. Can you
And
just tell us something about the TIBC, the ferritin store, the percentage situation, something about that?
okay, so ferritin is like the iron store of the body. So it's like it represents the total iron store in the body. So whenever there is increased ferritin, it suggests that I have sufficient iron in my body, and so body will send signals slowly for that. Okay, we don't need. You want me to say about
Yes,
the normal
yes,
absorption process?
yes. Anything which you can say. Yes, you're open.
Okay, so if we look at the iron absorption, it happens at duodenum. There are the enterocytes. It is the DMT1 transporters will
Okay,
bring the iron into the enterocytes, and then ferroportin is present, which will transport the iron from enterocytes into the bloodstream. And in the blood,
okay,
iron is in the blood, iron is carried via transferrin. It's like similar to the cars, and which transport the iron into the macrophages of liver and bone marrow. Okay,
okay,
okay. So now hmm. So whenever ferritin, okay, in the macrophages, iron is bound in the macrophages or the inside the cell. Iron is bound with ferritin. Okay, so the amount of ferritin represents the total iron store of the body. Now,
perfect.
if I have sufficient iron in my body, so ferritin will be high. So that will signal the liver to decrease production of transferrin, that okay, we don't need much more iron to carry, and it will cause the decrease in serum transferrin levels.
Okay,
And normally 33% of total transferrin is contains the iron, so that is it is like 33% saturated. That is the
okay,
percent saturation.
okay,
And now if we produce more transferrin, so obviously my percentage saturation will be low, but more free transferrin will suggest that my iron binding capacity will be high, so TIBC will be high,
okay,
right?
okay, okay. That's perfect. Let me just revise the other one. Anemia of chronic disease. We discussed. We have a chronic disease. We have acute phase reactant, hepcidin, telling your ferritin not to release iron, no hemoglobin, extra division, red blood cells. More ferritin because hepcidin again is telling not to release iron. Okay, less TIBC. We already know that. Sideroblastic anemia, problem with protoporphyrin. How can we have that? If the enzymes, ALA, ferrochelatase, any problem, right? It can be due to like B6 deficiency, isoniazid use, less protoporphyrin, less hemoglobin, extra division, microcytic anemia. But what would iron do? Iron would enter the mitochondria. It would just form a ring sideroblast, right? That's why we just call it as sideroblastic anemia. For the thalassemia, we have alpha and beta thalassemia. Alpha, 4, right? It's due to deletion. Beta is due to mutation. We have 4. If one is knocked out, deleted, no problem. If 2 is deleted, we have two problems. Either it can be cis on the same chromosome or on the other chromosome. Cis is bad for offspring. Is that clear? Then we have beta thalassemia. It's due to mutation. We can have like a moderate variant or a severe variant, right? In a moderate variant, if you have one normal and one defective or mutative B producing less amount of beta chain, it is going to give us beta thalassemia minor. But if both of them are bad, severely mutated, it can give us zero globin, which can lead to extramedullary hematopoiesis. That was all. Let's discuss macrocytic anemia, right?
Sorry, doctor. Can you repeat a bit about this on the
Cis and
alpha?
trans, right?
Yeah, cis offspring and trans. Can you talk about it a bit?
Okay, no worries. Like we have 4 chains, right?
So,
We discuss like 2 of them can be deleted, right? For example, if we have deletion of 2 genes, but there are 2 possibilities. Either the 2 can be deleted on same chromosome, or either one can be deleted on one chromosome and other on the next, on the other, right?
yep.
They are also 2, and this is also 2. But whenever we have deletion on same chromosome, it is basically known as cis deletion. Cis stand for same, right? On a simple or same chromosome, right? We have this deletion. Trans, whenever one is deleted on one chromosome and other on the other, right? So this is known as trans. Cis is bad for the offspring, right? For example, if this is like, let's suppose his mother is having that. So there is increased chances of baby to get both of them, right? If baby is getting both of them, and if from the father, if a single one approaches, it would lead to a thalassemia major. Is that clear?
Okay.
Okay. So let's discuss macrocytic anemia, right? Macrocytic anemia. So for the macrocytic anemia, we discussed that whenever the MCV is greater than 100. How can MCV be greater than 100? We knew a story. Whenever there is problem with DNA synthesis, as we know, DNA is responsible for cellular division, right? Is that clear? Hello?
Yes.
So problems with DNA can lead to inappropriate division, right? If we have inappropriate division, what happens? It would lead to a big cell. You can't divide it. It's going to be big. It's going to be macro. Can I say that?
Yes.
Yes.
Yeah. How can we have problems with DNA? We know DNA is made up of folate, right? Tetrahydrofolate. The pictures we discussed already. Like tetrahydrofolate, bound to methyl. You have a lot of your MCQ, remember, related with alcoholism, right? Malnutrition. It's gonna give methyl to B12. B12 is gonna receive this methyl. It's gonna give it to homocysteine. Homocysteine is gonna be converted into methyl malanoic acid. So tetrahydrofolate once bind to methyl cannot participate in DNA synthesis. Whenever the methyl goes to B12, then it can leave the reaction and participate in DNA synthesis. So can I say whenever I have tetrahydrofolate deficiency or even B12 deficiency, it would lead to problems in the DNA? Is that clear? Hello?
Yes.
Yes,
Yeah.
sir.
Yes.
Okay. If I have problems with DNA, so it would lead to macrocytic anemia. Not only the red blood cells are going to be big, the neutrophils, all of the actively dividing cells. You are going to see hypersegmented neutrophils, right? You are going to see like big epithelial cells as well, right? Hello?
Yes.
Okay. So let's discuss folate deficiency in a little bit more detail, right? So where do we have absorption of folate? Where do absorption of folate occurs?
Yeah.
Where?
Jejunum.
Jejunum.
Jejunum. Perfect.
Jejunum.
Okay, so we know that folate deficiency develops within the month, as Dr. Mahin discussed with you, like one of the common cause of that can be alcoholism, right? So we can also, like, you have certain anti-folate or antagonist, folate antagonist drug, methotrexate can also do that, right? So whenever we have folate deficiency, again, the idea is very simple, less DNA and macrocytic anemia, right? Hello?
Yes.
That's simple. Okay, if we do not have folate, can I say that the homocysteine are also going to be decreased, as we already discussed? There would be risk of thrombosis, because one of criteria of Virchow triad is satisfied, that is endothelial damage, because homocysteine damages your endothelium. Can I say that?
Yes.
Okay, perfect. Let's discuss something about vitamin B12, right? Vitamin B12 deficiency, because vitamin B12 can also cause macrocytic anemia. How? We discussed, once B12 is taken, it's bonded to a factor that is known as R binder, right?
Yes.
Then it's going to come, your pancreas is going to remove the R binder, and B12 is going to be attached with your intrinsic factor, which comes from your parietal cells. No, H plus and intrinsic factors come from parietal cell, right? Hello?
Yes, sir.
Once intrinsic factor binds to B12, then we can see absorption in ileum, right? Hello?
Yes.
So can I say that if you have problems with parietal cell autoimmune destruction, so you won't be having intrinsic factor, so you won't be having B12 binded to intrinsic factor, you won't be having reabsorption. If you won't have reabsorption, DNA cannot be formed. It can lead to macrocytic anemia. Do you guys support my statement?
Yes.
Okay. Do you guys support my other statement? If you have pancreatic insufficiency, R binder cannot be detached. If R binder isn't leaving its place, if it isn't, getting, diverse with B12, so you cannot attach intrinsic factor. Again, it would lead to B12 malabsorption. Again, it would lead to problems within the DNA. Problems within the DNA, it can lead to macrocytic anemia. Can I say that?
Yes.
Perfect. So these are the causes of vitamin B12 deficiency. And we discussed not only red blood cells are going to be big, right, or macrocytic, but also the neutrophils are also going to appear macrocytic, big, right, hypersegmented, right? Hello?
Yes.
Okay. So this was all about macrocytic anemia. And the next topic which we are going to discuss is normocytic anemia. Are you guys just following me?
Yeah.
Yes, sir.
Are you
Yes,
guys
sir.
just enjoying the bootcamp session or no? I'm quick. What do you guys think?
Yes, we are.
Okay, that's perfect. Normocytic anemia. As the name indicates, what's normocytic anemia? The size is normal, 80 to 100. It's normal. But we already know that we can have two possibilities. Either the red blood cells are being eaten up peripherally, right? Either something is destroying the red blood cells, then we can have anemia, or either we have underproduction. Remember? Hello?
Yes.
Yes.
Like if we are having normocytic anemia, we can have two situations. Like it's a common sense. Either you are killing the red blood cells peripherally, or either you aren't producing them from their precursor hematopoietic stem cell. So how to differentiate them? Question arises. How to differentiate them? Okay, we already know. If we are just eating a lot of red blood cell peripherally, so what if you have a working bone marrow? If you have working or normal bone marrow, what bone marrow are going to do? They are going to make a lot of immature red blood cells, also known as reticulocytes. Is that clear?
Yes.
Is that clear?
Yes.
Okay, if we have underproduction, it means problem lies within the bone marrow. It means the reticulocyte would be less, right?
Mm.
But we
Yes.
cannot directly, believe on the reticulocyte because you can have false elevation. Remember it? False elevation.
Yeah.
Yes. What was the concept for that? Even, for example, if I have red blood cells, for example, if I'm destroying them peripherally, but at the same time, problems also lie within your bone marrow. Again, the reticulocyte would increase, which are going to give me false elevated value. So for that, I have to correct the reticulocyte count. How do I correct the reticulocyte count? Correct it. We are going to take reticulocyte count. We're going to multiply it with hematocrit and divide it with 45, the normal value. Is that clear?
Yes.
Okay, so if we have anemia with increased reticulocyte count, it suggests that problem lies in the bone marrow or it's due to underproduction. If we have anemia, okay, if we have anemia, okay, let me just ask you guys a question, right? For example, if we have anemia, right, normocytic anemia, the mean corpuscular volume is normal, and the reticulocyte count is increased. What do you guys think? Okay, corrected reticulocyte count is increased. Please raise your hands.
It means it is because of the RBC's compensatory
Okay.
production. The bone marrow is normal
Okay,
here.
perfect. It means it's due to peripheral destruction, right? Hello?
Yeah.
Okay. So let's just, okay, before discussing peripheral
Then
destruction,
could
yes,
you
please.
then the corrected reticulocyte count and what it means? The example you gave.
Okay. So we discussed in our class in a big detail. So let me just do that again for you, right? So we already knew that, okay. Okay, just give me a second. Okay, we already knew that we can have, like, for example, if these are our red blood cells, right? If you are just killing or destroying the red blood cells peripherally, right? So what your bone marrow is going to do, if bone marrow is normal, it would just make a lot of reticulocytes, right?
Yes.
Hello? But at the same time, if I'm just killing red blood cells peripherally, but bone marrow isn't functional, like non-functional. So again, what happens? If I'm just killing the reticulocytes peripherally, the normal reticulocyte is 1 to 2%, right? Like in every 100 red blood cells, 1 or 2 are going to be your reticulocytes. But if I'm just killing the red blood cells, if I'm just decreasing the overall number of red blood cells and still this number isn't rising because problem is with bone marrow, right? So we can have false elevation. Are you just getting me?
Okay.
The example which I gave for that on that day was that, for example, if I have 4 people, right, 4 individuals, one of the individual is Canadian, and the other three are Americans, right? So, for example, if I want to find the ratio of Canadians, so I would say 1/4, right?
Mm-hmm.
But if I just remove one of the American, and now I just find the ratio, so it would be 1/3, a little bit more, right?
Mm-hmm.
I just remove another American guy if I just found the, so 1/2 again. So still you have a single Canadian, but if you are just changing the peripheral or the overall number of the people, you are increasing the ratio. It isn't increasing, you still have a single Canadian, but it's a false elevation. Are you just getting me?
Okay, yeah.
You can just relate this concept here. If I'm just destroying them with the constant number of reticulocytes, it can give me false elevated value. So I have to correct that. Simple.
All right, thank you.
Okay, so let's have 10 minutes of break and then we'll continue the session. Is that clear? So if you guys want to revise, so you guys can do revision. See you after 10 minutes. Hello? Are you guys enjoying the session? Hello?
Yeah, we're good.
Yes, sir.
Okay,
Sure.
thank you so much. Thank you. Hello, can you guys hear me? Hello. Hello.
Yes, yes.
Okay, so I want to just make an important announcement a little bit. We are going to discuss the details, but I want you to be aware that we have just called a researcher team. Soon they'll be joining us and we'll be starting our research along with our preparation as well. Is that fine? Hello? Hello?
Yes.
Okay, so as you people were promised that.
Research means like, do you mean like medicine, like research papers?
Yes, for research publications, right? So as in
Oh
the past
wow.
platform, we mentioned that we are going to prepare you for this match cycle, the current marathon people, right? So we'll be soon like announcing our step 2 marathon, right? We have decided the schedule, we have made the schedule, and we have discussed with a lot of research. I'll be just introducing their names. I think most of you guys would know them. They are some famous personalities, right? They're in the US. They're in the US. So you guys are going to work on like the meta-analysis and cohort, which are mainly counted in your match application and match processes, right? They're like considered more importance in your CV, right? Hello?
Yes, sir, that would be
Yes, doctor,
really
that will be
helpful.
nice.
Yes. So for that, we are gonna like first of all we have decided to do like mm, a meta-analysis. So it would just take some time, right? So like the least time which it take is like 4 to 5 months, right? So that should be in your mind. So that's why we have decided to start this process as soon as possible. Are you guys getting me?
Yes,
Hello?
doctor.
Yes,
Okay,
yes.
so I'll just announce that, but we have decided that we are gonna recruit a team of students, at least 20 students, right? So we are gonna give you a detailed webinar on that, but just be prepared for that within a week or two, right? Just be mentally prepared for that. And we are
Okay.
also like, and for US clinical experience, we'll be just giving you some links, right? So I've discussed with all of my community, and we are working hard on that. So just you guys should be mentally prepared for that, right?
Okay.
Okay. So let's start our discussion. Let's continue that, right? As you guys were promised that you guys are gonna, if you remember, you guys were promised that they'll be preparing you for this match cycle. Remember? I'll
When are you starting step 2 marathon?
We can't hear you, sir.
Hello, can you guys hear me? Hello.
Yeah,
Yes,
I was
yes.
asking about step 2 marathon. Have you
Okay, so
decided?
in the yes, so in the yes, so let me just tell you, in the last batches, like as I was doing tutoring in the last 3 batches and like one-on-one, so a lot of my students have passed their step 1 exam, right? But they are just like waiting for this match cycle, right? And I know that you guys can also get that opportunity to apply in this match cycle. So we'll be soon announcing that, right? But once you guys are just like done with your step 1, those who have booked their exam, we are gonna consult you one-on-one on that as well. Don't worry. And for you people, we'll be just announcing another marathon, right? So like in less time span, we'll be having 2 marathons. Step 2 for you once you guys just are done with your step 1, and like after 1 or 2 weeks, we are gonna announce that for those students who have like passed their exam already in the last marathons. So for them, we are just we just made the schedule because we have to look for a lot of factors for the match cycle, and for that you guys can now participate in the I would say that in the research, right?
Okay.
Okay. So let's continue our session further. Hello, can you guys hear me?
Yes.
Okay. So we were
Yes.
discussing normocytic anemia, right? Normocytic anemia. Okay. So we already discussed the reticulocyte count. We know that normocytic anemia can be, like peripheral destruction, or it can be due to underproduction. But another question which should arise in your mind is that peripheral destruction can occur in 2 places, right? Like either peripheral destruction can occur within the blood vessels, or the peripheral destruction of red blood cells can occur outside the blood vessels, right? So let me call the peripheral destruction which occurs in the blood vessel as intravascular hemolysis. Can I just name it intravascular?
Yes, doc.
Okay, and the destruction of red blood cell outside of the blood vessel, let me just call it as extravascular hemolysis. Right? Okay,
Right.
so let's discuss some of the intravascular and extravascular hemolysis, right? So for the intravascular hemolysis, for example, if the red blood cells is destroyed, it's gonna release hemoglobin in the blood, which isn't good for the blood. You know why? Because hemoglobin itself causes a lot of problem. You already know that it causes back pain. How? It can damage your kidney. It can cause acute tubular necrosis, which can give you a referred flank pain or back pain. Is that clear? Hello?
Yes.
Okay. What else? It can also cause coagulation, right? It can cause like thrombosis, a lot of coagulation. It can activate your coagulation cascade, right? So it can cause thrombosis. So basically, free hemoglobin isn't good, like if it's revolving or moving around here and there in your blood. For that, we have an adaptatory mechanism. What's that? Yes, haptoglobin, remember?
Yep.
So what haptoglobin would do, it would just take the free hemoglobin in order to avoid the outcomes of free hemoglobin, that is back pain, that is hemoglobinuria, and that is activation of coagulation cascade causing thrombosis. Is that clear? Hello?
Yes.
So let's discuss some extravascular hemolysis. So the first condition which we are going to discuss is hereditary spherocytosis. We already discussed in a big detail what is hereditary spherocytosis. You're going to see spheres, right? Why are we going to see spheres? Yes, because the cytoskeleton, which is made of spectrin, ankyrin, band 3, it isn't able to maintain the normal biconcave shape. So what happens? Although the oxygen carrying capacity is fine, but what happens? This spherocyte cannot survive through the spleen sinusoid, which is the graveyard of red blood cells. Hello? So your red blood cell is going to be killed in your
Yes.
spleen. That's the problem, right? Hello?
Yes, sir.
Yes, doctor.
Okay. So one of your UWorld MCQ, why do we have that? UWorld MCQ, why do we? Because due to less cytoskeleton, no cytoskeleton, defect in cytoskeleton, spectrin, ankyrin, band 3, right? So what would be the treatment approach? Remove the spleen. Is it right?
Yep, that's right.
But if you just remove the spleen, what's the problem with that? Did you remember Howell Jolly bodies?
Encapsulated organisms.
World MCQ, yes, encapsulated bacterial infection. One of your UWorld MCQ, Howell Jolly bodies. What are Howell Jolly bodies? Yes, Dr. Amis.
Yeah, okay. So they are the nuclear remnants which are present in the mature RBC. Yeah,
Okay,
nuclear
nuclear
remnants.
remnant. It appears
Mm.
as a blue inclusions. Remember? What about the
Yes,
fragility test? You know the fragility test. You're going to see rupturing of the spherocyte because they are so weak, right? They do not have the cytoskeleton. Is it clear?
yes, yes,
Okay, so we are going to see splenomegaly. Why? Because you are going to see killing of red blood cells within the spleen. Spleen is going to enlarge, splenomegaly, hemolysis, bilirubin gallstones, right?
Yes, that's
yes.
right.
Okay, perfect. So let's discuss sickle cell disease then, which is also an example of extravascular hemolysis. What happened in sickle cell disease? We are going to see sickling of the red blood cells. What's the problem with sickling? Oxygen carrying capacity is disrupted. If it's disrupted, if we have like sickle cell disease is a disease which is a chronic form, right? If one have this defective gene, you're going to see like a lot of sickling all over his life, which can cause autoinfarction, where of your spleen, you want MCQ, right? Spleen can become infarcted or functional asplenia, remember?
Yes, doctor. Yes,
Okay, it can lead to functional as what else? It can cause vaso-occlusive events in the small blood vessels, for example, of your fingers, causing dactylitis, your world MCQ, right?
Right. Yeah.
Yes, it can cause infarction of your medulla, giving you renal papillary necrosis. Remember?
Yeah.
Okay, so if we know that sickle cells or sickling of the cells can do that, so we must know the cause of that. What's the cause? Yes, Dr. Muskan is going to tell us. Hello? Dr. Muskan, are you here? Okay, Dr. Shafiq, yes, please. Anyone else?
Yes, yes, doc. What's the question?
The question is that why someone can have sickle cell anemia? Why do we have sickling on the first place?
Because of the abnormal hemoglobin in the red blood cells.
Okay, so can I say that it's a genetic problem? So if there is some problem with the genetic, or to be very specific, if a single amino
Yeah,
acid,
yeah, yeah. It will be
glutamic,
substitution of glutamate with the valine.
yes, perfect, right? So whenever the single amino acid, glutamate or glutamic acid is replaced by valine, it can give us this problem, which we discussed in detail, right? So we're gonna have two variants, either a sickle cell trait or a sickle cell disease. What's a sickle cell trait? If one of the beta chain is normal and the other is abnormal, like homozygous and heterozygous. If we have homozygous, it's gonna give us sickle cell disease, hemoglobin S. Is that clear?
Yes.
And it can give us a lot of problems. Okay, so in sickle cell disease, if the sickle cells are being destroyed again and again, so can I say that like it can also lead to extravascular hemolysis because
Yes.
you are just killing a lot of red blood cells. So how, what's the presentation of extravascular hemolysis? Yes, Dr. Shafiq, favorite topic.
Yeah,
Hello.
there will be extramedullary hemoptysis. There will be
Okay, so what would how would these individuals present?
they will present with
Chipmunk
hepatomegaly.
faces, chipmunk faces,
Yes.
clear-cut appearance, splenomegaly,
Yes.
hepatomegaly, right?
Yep.
Okay, perfect. So next thing which we are going to discuss is some lab findings. So what would be the lab findings? The idea is really simple. If we have autosplenectomy, so can I say we'll be seeing Howell Jolly bodies?
Yes.
Perfect. Can I say that we'll be having increased risk? Okay, you guys already know that in encapsulated bacteria, right?
Yep.
Okay. Okay. It can also cause renal papillary necrosis, which we already discussed, right? Okay. So it was all about hemoglobin. Okay. It was all about sickle cell disease. So let's come to our next pathologies that are intravascular hemolysis. Hemolysis which occur within the vessel, intravascular hemolysis. So the first one which we'll be discussing is paroxysmal nocturnal
Actually,
hemoglobinuria. It means that paroxysm sometimes nocturnal at night. We are going to see hemoglobin within the
urine.
urine. It means like killing of your red blood cells. Once the red blood cells is destroyed, then we are going to see hemoglobin in urine, right?
Yes, doctor.
Okay, why do we have that? We discussed that, for example, this is our red blood cells. So we are going to have a pillar, right? What was the pillar? GPI. On the GPI, we had decay, DAF. Basically,
Yes.
it inhibits C3 formation, or it help red blood cell to save itself from complement system. But if we
Yeah.
do not have this pillar, we won't be having DF. So now what happened? Complement system would destroy your red blood cell, leading to hemoglobinuria. But why specifically at night? Because specifically at night, what happens? We're gonna hypoventilate. Hypoventilate is gonna give us acidity,
Yes.
acidosis. Acidosis can activate your complement system. Once complement system is activated, what happens? It would lead to killing of your red blood cells.
Yes.
Is that clear?
Yep.
Okay. So we discussed that GPI is not only
Excuse me,
present.
can
Yes,
you
please.
repeat this concept again?
Okay. Paroxysmal nocturnal hemoglobinuria, right? So we discussed that it occurs at night. Why? Because at night we are hypoventilating. Whenever we are hypoventilating, it means we are retaining carbon dioxide, right? Hello?
Yes.
Yes, sir. We are retaining carbon
Retention of
dioxide.
carbon dioxide lead to acidosis, and acidosis is a stressful situation which can activate your complement system. So if the complement system is
All right.
activated at night, you do not have someone to save your red blood cells, so it would start destroying your red blood cells. So once this guy, wake up early in the morning, you'll be having hemoglobin in his urine, dark urine, right?
Yes.
Okay, so that's why we just named this pathology as paroxysmal nocturnal hemoglobinuria. Is that clear? But not only red blood cells, white blood cells and platelets also need that GPI or the pillar to save itself. So you can also see problems with platelets like thrombocytopenia and things like that. Is that clear? But if we have
It's clear,
hemoglobin,
sir.
if we have hemoglobin in blood, we discussed hemoglobin can cause a lot of problems. It can cause thrombosis. So the most common cause of death in these individuals is thrombosis. Thrombosis of, yes, hepatic circulation, hepatic vein. Hello?
Yes,
Hello?
sir.
Yes, hepatic vein, portal veins, cerebral veins. It can cause a lot of problems. Is that clear?
Yes, doc.
Okay, so let's discuss our next pathology, G6PD deficiency. We already discussed. Normally, your red blood cell is exposed to H2O2, right? But in order to save itself from this, H2O2 or free radicals, we have an antioxidant. What is that? Glutathione, right? But for the glutathione to survive or to regenerate, we have G6PD, which give us NADPH, right? NADPH help in regeneration of your glutathione. Is that clear? Hello?
Yes, sir.
Yes.
Yes, sir.
Once glutathione, okay, so for example, if you have deficiency of G6PD, it means you do not have NADPH. If you do not have NADPH, it would lead to, yes, less regeneration of glutathione. Less glutathione regeneration would lead to H2O2 induced damage of your red blood cells or free radical damage of red blood cells, which is going to lead to hemolysis that would be intravascular. So simple. Is that clear?
Yes.
Okay.
Yes,
So
sir.
okay. So how can we have the exacerbation of this pathology? You guys already aware of, right? Like certain oxidative stress. Any infection can increase the free radicals formation. Like for example, with some drugs, sulfa drugs. You have a word MCQ on that, right? Anti-malarial drug, fava beans. Again, very important. Is that clear? Hello.
Yes.
Okay, once the hemoglobin content of the red blood cells is dead, it's going to appear in the form of His bodies. Remember?
Yes,
Hello?
sir.
Yes.
What are His
Right.
bodies? His body are simply the dead hemoglobin present within the red blood cells. Why do we have dead hemoglobin? We already know that. Why? The reason for that is no G6PD, no NADPH, no glutathione, and increase death of hemoglobin appearing as His body. You have a word MCQ on that. Is that clear?
Yes.
Okay. So this was all about your G6PD. The next intravascular pathology which we are going to discuss is immune hemolytic anemia. We already are aware of that. Immune hemolytic anemia. Who is going to tell us immune hemolytic anemia because we discussed it like several times? Yes, please. Dr. Muskan, are you here? Hello? Anyone else? Please raise your hands. Hello? Are you guys able to hear me? Hello?
Yes, doc, we can hear you. What's the question?
The question is that please tell me what happens in autoimmune or immune hemolytic anemia.
Yeah, hemolytic anemia. It's an abnormal autoimmune hemolytic anemia.
Okay. It's an autoimmune disease. It means that what happens, your red blood cells are going to be tagged by antibodies, right? and it can cause destruction of your red blood cells, complement mediated, right? But we know we have two variants of that, a warm and cold. Warm
Yes.
occurs in central bodies, right? So in the
Yep.
warm, the antibodies tagging, okay, it's an example of type 2 hypersensitivity. We already know that, right? Hello?
Yep.
Okay. So in warm, IgG would be responsible for that. And for cold, IgM, right? IgM causing problems. But we discussed that warm is going to be intravascular or extravascular. Yes.
It will be.
Extravascular.
Okay.
Extravascular.
Yes. Anyone?
Extravascular.
Extravascular. And what about IgM?
IgM is intravascular.
Intravascular. Perfect. So IgM is going to activate your complement system within your blood vessel, causing problems. And IgG, your spleen, is going to eat your red blood cell, giving you immune hemolytic anemia. Is that right?
Yes, sir.
Okay. So what about the test, Coombs test? For example, if I want to see whether I have certain antibodies against the red blood cells, for that we use a Coombs test. We have a direct Coombs test and indirect.
Indirect.
So what's the idea of direct Coombs test?
We will detect the antibodies directly on the red blood cells
How do we do that?
by the isolation of the by the using of the blood of the patient, isn't it? The whole
Okay, so we'll just take blood of a patient. If
Anti-IgG
he have
detected.
antibodies, what happens? We are going to anti-IgG. If you see agglutination basically confirm. Yes, agglutination would confirm that yes, we have antibodies. And what about indirect? We are going to see, antibodies within the plasma, right?
yes.
So within the plasma, we are going to see antibodies. For that, what we are going to do? We are going to take the plasma, we are going to add some red blood cells, and then we are going to add anti-IgG, right? So this was the idea of direct and indirect Coombs test. Is that clear?
Yes, sir.
Okay, so microangiopathic hemolytic anemia is also intravascular hemolysis, and I think we have discussed that the causes, so we'll just skip that.
Yes, doc.
Hello?
Yes.
Okay, last topic for your red blood cell module. Anemia due to underproduction. Anemia due to underproduction. I would say simplest and highest yield topic. Underproduction. What happens in underproduction? We can have parvovirus B19 infection. Is it clear? We can have aplastic anemia. What happens in aplastic anemia? Yes.
Yeah, there will be
Pancytopenia. We are going to
yes,
see
yes, yes.
pancytopenia. What are the causes for that? It can be due to certain chemicals damage, autoimmune damage of your hematopoietic stem cells.
Right.
Right?
Yes.
So the treatment is cessation of the causative agent. If certain chemicals are causing that, remove the causative agent. If certain medications are causing that, just remove that, right? So it's a kind of supportive or, treatment. Is it clear? Aplastic anemia. And with that, we are ended with your red blood cell module. So I need 5 minutes of break to start our white blood cells lecture. Is that fine?
Yes, doc. Thank you.
Okay, so you guys are done with 2 modules, revision, bootcamp. Congrats, congratulations so much. Okay, any questions about research? Are you guys interested in participating in research?
Yes, doc.
Yes, doctor. We
Okay,
are very much
okay.
interested and
Let me just
waiting for
ask.
you.
Okay. Let me just ask from everyone, because I'm just seeing so little participants. So if you aren't. So what's the So. So, Dr. Abdul Rauf, are you just interested? No?
Yes, sir.
Okay, that's perfect. What about Abida, Dr. Abida?
Yes, sir.
Okay, I'm just asking from each and everyone. So, in order to confirm, just show some enthusiasm, please, for our
Okay.
upcoming.
Yes, sir.
Okay.
So nice of you. We are very much interested in it.
Okay, that's perfect. But the most recommended one is like cohort and and like your as we have decided the cohort studies and meta-analysis, right? So these two are like considered like of much importance there. So although it's going to take some time, but perfect. So for that, what I suggest is that from now you guys can just like those who want to just make team of their own. So I need 20, at least 20 participants per team, right? So you can just discuss it with one another if just you want someone to be there so that we can just boost up this process, right? Because as I'm seeing that most of students are like an old graduate, so it's like I feel the need that we should also be working on the CV, right?
Yes,
Yes,
Doc, I
doctor. That
agree.
is
Yes,
that
it's
is
very
really.
helpful.
Okay, perfect.
Yes,
So
sir.
so I need some 5 minutes, please, just to drink a cup of water and just come back with the white blood cell model. What do you guys say?
Yes, doctor. When can we expect that webinar
Just
on the
expect it
research?
within 1 or 2 weeks. We are already, working day and night. We have just contacted, famous, research publications. I'm going to, I don't want to reveal the identity for now, please.
Okay, that's very nice, doctor. Thanks for the effort.
Yes. Thank you so much.
Yeah, thank you so much for the
Thank you
because
so much. Thank you so much, doctor.
it's really helpful for us being old graduates.
Yes. So and it just takes a lot of
Yes,
time.
yes,
So it would be best that you guys can just start it from now, right?
Yes. Thank you.
Okay.
yes, doctor.
And another thing which I want to mention, like as we know that it's a new platform, so most of the people are just trying to like misguide students. So you should just expect if a message from admin. Okay, let me just like you guys know Dr. Laibas and Dr. Hamzan, right? So they are like basically your code, right? So apart from that, if anyone approaches you that if they are just claiming of being our team, so please that isn't acceptable, right? So whatever you want to ask, you can just contact me, Dr. Hamza or Dr. Laiba, right? No other tutors, like even not me, right? I'm your tutor. So it's a job of your Dr. Laiba and Dr. Hamza to you guys can just discuss it with them. But since I'm here and I love to give you some information which we are planning of. So
Thank you so much, Doc.
welcome, you're welcome.
Thanks, doctor.
Hello, can you guys hear me? Hello, hello. Are you guys able to hear me? Hello.
Yes, we can.
Yes,
Yes.
Yes, sir.
yes, please.
Okay, perfect. So why are the participants just leaving the meet? I think you guys are drained out or what? Hello.
No, doctor, we are here.
Okay, so let's start our WBC module, right? White blood cells. Before discussing WBC, so we discussed that normally white blood cells comes from hematopoietic stem cell. You already knew the lineage. We discussed some of the general phenomena like what is leukopenia, what is leukocytosis, when are we going to see leukopenia. We discussed the normal white blood cell count. We know white blood cells are basically policemen of your body, right? So they're very important cells. They comes from hematopoietic stem cell, which we are going to discuss. Don't worry about that, right? So what is leukopenia? Whenever the leukocyte or white blood cells are less, and neutrophils are also your white blood cells, so we can just name less neutrophils as neutropenia, right? There are a lot of causes of neutropenia. For example, we discuss if anyone is on chemotherapy, right? So chemotherapy can disrupt your hematopoietic stem cell and it can lead to neutropenia, right? Hello?
Yes.
Severe infection, we discuss whenever we have severe infection, all of the white blood cells are going to leave to the site of infection, giving you neutropenia, leukopenia. Is that right? We discussed we can also have lymphocytosis or leukocytosis, increase amount of white blood cells, right? So these are some general terms. So let's just come directly to hematopoietic stem cell, different lineages. So we discussed we have hematopoietic stem cell, CD34. We have two lineages. We discuss your myeloid and your lymphoid. Are you guys just following me? Those who haven't drawn the diagram that day, so they can just do it now. Just take your pen and paper because we are going to discuss leukemias again, right? So from the myeloid lineage, we see we have erythroblast. Erythroblasts are going to mature into red blood cells. Remember, we have myeloblast.
Yes.
Myeloblast matures to
Granules.
granulocytes, neutrophils, basophils,
Eosinophiles.
and eosinophils. Perfect. We have monoblast. It can mature into monocytes. We have our last one, that is megakaryoblast. That can mature into megakaryoblast. Then we discussed our lymphoid lineage. Lymphoid lineage is furtherly divided into B cells and T cells. B lymphocyte or B lymphoblast first, then naive B cells, hello, and plasma cells, right? T lymphocytes into T lymphoblast, naive T cells, and then we have two kinds of cells. We discussed in immunology in detail,
CD8 and CD4.
and CD4. Perfect. So let's discuss our next pathology, that is leukemias. For the leukemias, we discuss we have acute and chronic. For the acute, we discuss whenever we have neoplastic proliferation of blast greater than 20%. What's the problem with that? Problem is pancytopenia, occupying the normal space and leading to pancytopenia. Remember?
Yes.
Okay, so greater than 20% of blast, but blast can be present on both of the lineage, even on the lymphoid lineage and myeloid lineage, right?
Right.
So whenever we have like greater than 20% lymphoblast in the lymphoid lineage, greater than 20% lymphoblast in the lymphoid lineage T cells. So first of all, we are going to name it as acute lymphoblastic leukemia. But we can have two variants, either B or either T. So we are going to name it BALL and TALL. How to differentiate both of them? On the surface marker, greater markers, remember 20, 21, 16 for B cells, small number markers 6, 8, 10, right, for T cells. Is that clear?
Yes.
Okay, so we have BALL and TALL. Let's come to the myeloid lineage. Here we also see some blast. If we have greater than 20% blast, we call it as acute. Okay, the first thing. Yes, AML, right?
Yes.
How to differentiate AML from ALL?
Myeloperoxidase.
Myeloperoxidase or rods causing DIC and TEDT, right? Is that clear?
Right. Yes.
Okay, then if the blast in the myeloblast lineage increase, we are going to not call it as acute, yes, promyelocytic leukemia. You were MCQ, what's the translocation there? 1517, right?
Yes.
Yes, the RAR is disrupted. No maturation. No maturation leads to more blast. More blast lead to acute myeloid leukemia. Is that
Yes.
clear? Okay.
Yes.
Then we discuss, we can also have acute monocytic leukemia if the monocytes or the monoblast increase acute monocytic leukemia. And what's the characteristic for that? It infiltrates your gums. We can have megakardioblastic, right? Acute megakardioblastic leukemia.
Yes.
It won't be having MPO again and again, no MPO because they cannot fight off infections, bacteria. Is that clear?
Yes.
Okay, perfect. Let's discuss chronic leukemia. What happened in chronic leukemia, the definition for that was if we have neoplastic proliferation of the mature cells, right? So let's come to this part first, right? On the lymphoid lineage, right? So on the lymphoid lineage, what's the name for that? Chronic lymphocytic leukemia, CLL, right?
Yes.
CLL. So we discussed we can have two variants, either of naive B cells or the more mature plasma cells. For the naive B, basically, we have smudge cells. Remember? Smudge cells. Your UWorld MCQ, splenomegaly, right? We have splenomegaly or no? Yes or no? No, we didn't have.
No.
Lymphadenopathy was there. Yes. How you guys
Yes.
click the word? Lymphadenopathy, right? Smudge cells,
Yes.
a little bit immature cells, right? Lymphadenopathy, hypogammaglobulinemia. Why? Severe chances of infection, less or inappropriate formation of your antibodies. And a more mature one was hairy, right? Hairy cell leukemia. The characteristic finding, you will MCQ, middle-aged man having, yes,
Hairs,
Linament
hairs,
and
and trap.
cytoplasmic, here's kind of cytoplasm. And they used to trap people, right? So trapping for splenomegaly, remember?
Yes.
Yes. And what do trap mean? Tartrate resistance acid phosphatase. What's the treatment? Give them cladribine, which would inhibit your yes, which enzyme? It is a CD8. Yes, and it can cause problems there, right?
Yes.
Okay, on the T side, let's discuss the T sides, right? So Dr. Mahin already did that with you. And here I think I discontinue the lecture. So we are going to spend a little bit time. On the T side, you can have like T cell leukemia, lymphoma, or another one is mycosis fungoides, right? So again, you can just consider two variants of the mature cell. Like as here also we are going to see naive B cells and more mature variant, right? So adult T cell leukemia, neoplastic proliferation of, yes, T cells, right? Hello?
Yes.
Okay. But it's highly associated with a virus. What's that?
You can
H.
show your screen.
Sorry?
You can share your screen. Not
I'm
showing
sure.
over there.
Can you guys just see this?
see a screen.
Yes.
Okay, perfect. So for the adult T cell leukemia or lymphoma, basically we have neoplastic proliferation of mature T cell, right? So again, you can have two variants. One is ATLL, that is adult T cell leukemia, and the other variant is mycosis fungoides, which Dr. Mahin just discussed with you guys, right? So what happens in the first variant is that you are going to see this is going to be due to a virus that is HTLV1. Can anyone just tell me what is HTLV1? Yes, you guys are going to answer me that.
You're asking the full form, doctor.
Yes, what's the full form?
Okay, so it's human T lymphocytic virus, I think.
It's a T lymphocytic or T lymphotropic?
Or T lymphotropic, I think.
Yes, as the name indicates, human T Lymphotropic. What is tropic? We discussed in endocrinology. Tropic, anything which induces things, right? Tropic effect. Tropic effect means growth kind of effect, right?
Yes. Mm-hmm.
Yes.
So if so, you can just see towards the name of this virus, human T lymphotropic virus 1. It means it would have a tropic effect on T. Tropic effect can lead to neoplasia. Can I say that?
Yes.
Hello?
Yes,
Okay.
you are here.
So okay, so you can have like a skin rash and generalized lymphadenopathy again. If you have a lot of T cells in the paracortical area, it can lead to lymphadenopathy. It can lead to hepatosplenomegaly as well because T cells are also present there. But it can also invade your bone, giving you some lytic lesion hypercalcemia. Is that clear?
Yes.
So we are going to see lymphadenopathy. That's so simple. We are going to see hepatosplenomegaly because they are the sites where the T cells sit, right?
Right.
Okay. Then the other variant is mycosis fungoides. Mycosis fungoides. What happens in mycosis fungoides? Again, it's basically neoplastic proliferation of mature T cells. That is CD4 T cells, right? Hello? But what's high yield and important thing which you guys should remember, these neoplastic T cells can aggregate your skin and it would appear in a form of skin rash, plaques or nodules, right? So whenever you see involvement of skin and the history is of CLL, right? Are you guys getting it? So you should just think of mycosis fungoides, right? Which is basically in the mature neoplastic condition of CD4 cells. So it would just appear in a form of a micro abscess, which Dr. Mahin just told you, portrait micro abscesses, right? So they can aggregate in the skin, they can give you some abscesses, and those abscesses are basically known as portrait micro abscesses. Okay, let me just write down it clearly, right? Portrait micro abscess. Is that clear? Hello?
Yes,
Yes,
sir.
Doc.
Okay, so this was all about the mature neoplasia of lymphoid lineage. Let's just come, for example, if you have neoplasia of the mature cells of the myeloid lineage. Yes? Hello?
Yes.
So for example, if these mature cells have neoplastic condition, that CML, you already know that. What's CML? Chronic myeloid leukemia, right? Chronic myeloid leukemia. Can you guys just hear me?
Yes,
Hello?
you.
Yes, please do
Yes, Doc.
participate. It's a revision session. Okay, who is gonna tell me what happens in chronic myeloid leukemia? Very high yield, very high yield. Please raise your hand. Dr. Gyanchi. Dr. Gyanchi, are you here?
Yes, doctor.
Okay, perfect. So can you just tell us something about chronic myeloid leukemia? What happens in chronic myeloid leukemia?
Chronic myeloid leukemia, doctor, it's because of a genetic mutation in the BCR-ABL.
Okay, like 922 Philadelphia or BCR ABL. If we have genetic mutation of BCR ABL, what happens then?
There is a...
It would increase the tyrosine kinase activity, right?
Yes.
And if the tyrosine kinase activity is increased, we know tyrosine kinase is basically a messenger, right? So it would just keep on sending a lot of messages to the cells to divide. And a lot of division is going to lead to neoplastic condition. And what's specific? The basophils count are going to be increased, right?
Yes.
Basophils increased. Is that clear?
Yes, doctor.
Okay, so how to distinguish CML from leukomoid reaction? A lot of you want MCQ and so simple, right? So in leukomoid reaction, we are going to see a lot of cells, not only basophils, right? But here we are going to see a lot of basophils, right? And negative leukocyte alkaline phosphatase, negative LAP, yes. Remember?
Yes, Doc.
Yes.
Yes, sir. Yes.
Okay. So that was all about CML. Now let's come to mature neoplastic condition of your erythrocytes, red blood cell. That is polycythemia. We already know that. If you have a lot of red blood cells, it's known as polycythemia, right? Hello?
Yes, sir.
Yes.
But
Yes,
if
sir.
it's due to some genetic problem within the hematopoietic stem cell, we basically call it as polycythemia vera, right?
Yes.
Polycythemia vera. The idea is really simple. We have a mutation that is JAK2 kinase mutation. And JAK2 kinase mutation would lead to again increased signaling. Increased signaling would just tell the cell to just give me a lot of red blood cells. Lot of red blood cells. What would be the presenting feature? We already know that in the history you'll be seeing a guy. He had a shower, and right after shower he have like a rashes, which basically indicates histamine release and problems, right? So what happens to viscosity of blood if the red blood cells increases? Hematocrit or viscosity? Yes.
Increase.
Increases.
Viscosity would increase. What happens to hematocrit? Again, it would increase. Hematocrit and viscosity would increase. Flushing due to congestion, right? Itching after taking a bath. Why? Due to histamine release. One of your UWorld MCQ. Histamine release, right? Causing itching. Is that clear? Yeah, so
Yes.
Dr. Mahin told
Yes.
you what's the treatment option? Phlebotomy, right?
Yes.
And hydroxyurea. Perfect. Phlebotomy. Okay. So this was polycythemia vera. Let's discuss our next two pathologies that are essential thrombocythemia. What is essential thrombocythemia? If the mature cells, that is platelets increase, right? The megakaryoblast increase. That is known as essential thrombocythemia, right? So what happens? It's basically neoplastic proliferation of mature cells that are platelets, increase platelets. Essential thrombocythemia. What happens? The idea is really clear. If we have a lot of platelets, so what happens that again it's associated with JAK2 mutation, right? So a lot of thrombosis, a lot of bleeding disorders if you are consuming the platelets. Is that clear? It can also lead to gout. How? You have increased turnover of the cells. Once the turnover increases, you have a lot of DNA coming out. Okay, will we be seeing gout? Yes or no? In this
Yes.
condition.
Yes.
No, sir.
No.
Okay, that was for your confusion. So for that, you are going to tell me that do platelets have nucleus?
No.
No.
So if platelets do not have nucleus,
Then they don't have.
they do not have purines. If they do not have purines, how can you generate uric acid? Right? I think you guys are sleeping. Okay. I just go to there. Hello?
Sir,
Yes?
can you repeat it again?
Okay, I'll just repeat it. Okay. So as you know that whenever we are having a neoplastic condition, we are going to have a lot of turnover, right? Like in myeloproliferative disorders, what happens that a lot of turnover of the cells, like you are just making cells and killing cells, making cells, killing cells, right? This is basically, known as increased turnover, right? Right? So if the neoplastic cells are having nucleus or DNA, DNA is made up of purine, right? Hello.
Yes,
Yeah.
doctor.
Yes.
Yes.
Purine can be metabolized into uric
Yes, sir.
acid. This uric acid, once deposited in your joint, can give you gout, right?
Yes. That's
We'll be
right.
discussing that in MSK. Don't worry about that gout. So, if we have a lot of DNA, but for the platelets, if we have a lot of platelets, cancer in the platelets, essential thrombocythemia, we won't be having risk of gout. Why? Because platelets do not have DNA. Platelets do not have nucleus. So how can we have gout? How can we have purines? How can we have uric acid? Is it clear?
Yes.
It's clear,
Okay.
yes.
Okay. So the next topic is going to be lymphadenopathy. Okay, lymphadenopathy and lymphomas. So if you guys can just give me a 3 minute of break, so that would be like, so great because I want some break. Hello?
For sure, sir. Yes,
Sure,
please.
sir.
Yes,
Okay,
please.
all right.
Yes. So we are just left with, a little bit topics only lymphadenopathy and lymphoma. And with that, we'll be ending the bootcamp session, right? So just please give me like 2 to 3 minutes of break. I'll be back, right?
Okay, enjoy.
Hello, can you guys hear me? Hello.
Yes,
Yes.
Doc.
Okay, just please wake up. We have a little, like 30 to 40 minutes of class remaining, so please just participate. Okay, so now you guys are gonna participate. I won't be talking, right? Because I think you people are sleeping. Okay, so can you just tell me what is lymphadenopathy?
Enlarged lymph nodes.
Enlarged lymph node, but we can also see enlarged lymph node in infections. Like for example, if you have a bacterial infection, follicular area is going to enlarge. So how to differentiate if this enlargement is due to some cancer or if it's a normal enlargement? Yes,
If the lymph node is tender and mobile,
perfect.
and
Pain. If you have an infection which leads to enlargement of lymph node, so we are going to have painful lymph nodes, right?
an
If
enlargement
it,
usually after like
good,
catching cold.
yes, if it's a lymphoma, it would be painless, right? Hello?
Yes,
Yeah.
doctor.
Okay, perfect. So let's discuss lymphoma in a little bit detail, right? What is lymphoma? It's again enlarged lymph node, neoplastic proliferation of like lymphocytes present within the lymph node. It would just appear in a form of a big, extranodal tissue. It can appear or big lymph node. So we have basically divided it into two types: Hodgkin lymphoma and non-Hodgkin lymphoma, right? Okay.
Yes.
So non-Hodgkin lymphoma is the common variant, and Hodgkin lymphoma is this common variant, 40%, right? Hodgkin lymphoma further is divided on the basis of cell types. Either it can be B cell or T cell. Let's discuss the B cell variant, right? So B cell variant can further be divided on the size of that cell, size of B cells. There can be small B cell, it can be intermediate size B cells, or it can be large B cells. Are you guys able to, understand?
Yes.
Non-Hodgkin lymphoma, it can be B type, it can be T type. We are going to discuss this in last. For example, let's discuss B type. B type further is divided into small B type, intermediate size on the basis of size, and large size B type, right?
Yes.
Hello. So let's discuss the small B cell type in a little bit detail. Hello. So
Yes.
the small B cell type further is divided into three variants: the follicular, yes,
Mental.
Mental,
mantle, and
marginal.
marginal. How do we get this classification? We know that we have follicles, right? In the follicles, we discussed B cells are gonna sit there, right? Okay, surrounding the area of the follicle, this area is basically known as mantle area. And surrounding the mantle area is marginal area, right? So this classification of small cell B lymphoma, non-Hodgkin lymphoma is whenever the cancer is only limited to the follicles, it's known as follicular lymphoma. Whenever the cancer is spreads to the mantle area, it's known as mantle cell lymphoma. When it spreads to the marginal area, it's known as marginal cell lymphoma. That's so simple.
Yes.
So let's discuss follicular lymphoma in a little bit detail. Follicular lymphoma. What happens in follicular lymphoma? Again, we know small cell type, non-Hodgkin, B cell. Okay, for the B cells, what's the surface marker? CD20, right? And it will be painless as it is a cancerous process, right? So what happens that the architecture is going to be like follicles, right? So they will be just growing in a form of follicles and limited to that area. That's why it's known as follicular lymphoma, right? Okay, what happens? We have 14, 18 translocation. What happens to 14 translocation? You know that B cells are responsible for making your antibodies. Antibodies have heavy chain, Ig heavy chain, right? So this is the normal gene which basically codes for heavy chain of your. Are you guys able to understand?
Yes.
Okay, but what happens? From the 18, something comes and attached to 14, that is translocation. And now 18 is also going to be amplified. What comes from 18? BCL2. We know what is BCL2. For example, you have mitochondria. BCL2 are basically the watchman, right? Sitting on the surface of mitochondria. And it won't allow the release of caspases, right? What are caspases? Okay, normal apoptosis. If the caspases came out to cytoplasm, what happened? It would kill your cell. or apoptosis. Is that clear? Hello?
Yes, sir.
So if we are getting a lot of BCL2, a lot of watchmans, right? BCL2. So can I say that it's very less likely for the apoptosis to happen?
Yes, sir.
If we do not have apoptosis again, I'll say it's a neoplastic condition because we need apoptosis is a normal phenomenon, right?
Yes.
Okay, that's perfect. Let's discuss
Doctor, can
mental.
I just Doctor, can you just repeat about the BCL2 part?
Okay, so what happens in the normal apoptosis? We will be discussing normal apoptosis in the first chapter of pathoma. What happens in apoptosis normally? Okay, how do one of the process of apoptosis? Apoptosis can happen like there are 2 to 3 processes, right? One of the process is that you have mitochondria. In the mitochondria sits caspases. They are basically enzymes, caspases, right?
Yes.
Normally, BCL2 sit on the surface of mitochondria and they do not allow the caspases to come out. But if I want to undergo apoptosis, so what happens? BCL2 have to be knocked. You are going to remove the watchman, so caspases is going to come out and it would lead to killing of the cell.
Okay.
Right? So BCL2, I can say that it avoid apoptosis to occur.
Apoptosis.
So if we have a lot of BCL2, it means due to this translocation, right? So it means we will be having less apoptosis. Less apoptosis leads to what? Cancer.
Yes.
If we are just making cells and aren't destroying them, it would lead to cancer. Hello.
Yep.
Okay, so the next one is mantle cell lymphoma. We discussed what is mantle cell lymphoma if these small B cells spread the mantle area, right?
Yes.
So again, it's of B cells. What happens? What's the translocation? 11.
11 and
14. So 14 we discussed normally is for Ig heavy chain. But what comes from the 11? That is cyclin D, right? And what cyclin D do? It promotes G1 phase and S phase. What is G1 phase and S phase of your mitosis? S phase can simply be, called as a synthesis phase, right?
Yes.
So you are synthesizing a lot of cells. Simply you can think of, right? Again,
Yes.
if you're synthesizing a lot of cell, it can lead to cancer. And
Yep.
this cancer can spread to the mantle zone, which will just give you mantle cell lymphoma. Is that clear?
Yep.
We have marginal cell lymphoma. Whenever lymphoma spread to the marginal zone, how
So
can we get
11.
that? Chronic inflammation like Hashimoto's thyroiditis, H. pylori gastritis, maltomas, right? So all
Yes.
of them can increase the risk of neoplastic B cells, which can spread the marginal zone. That's all. Is that clear?
Yep.
Let's discuss intermediate size cell, B cell lymphoma. Like we discussed the small cell. Okay, let me just repeat. We have non-Hodgkin, can be B cell, cell can be small, intermediate, or large. For the small cell, we discuss it can be follicular, mantle, and marginal. Let's discuss intermediate size, B cell, right? So example for that is Burkitt lymphoma. Okay, what would be the classical presentation of the Burkitt lymphoma? Small child having a jaw mass, right?
Jaw mass, yes.
Caused by EBV, your UWorld MCQ, right?
Yes.
Okay, what can happen? What translocation?
It's
814.
814.
Okay, again, we know 14 is for RG heavy chain. What comes from 8? From 8 now you are going to see CMYC. And CMYC increases the growth phase. If he increases the growth phase, again, it can lead to formation of a cancer. That's so simple, right? Hello?
Yes.
What about starry sky appearance, highest yield, a lot of inflammatory or mitotic index?
Yeah.
Okay, perfect. Let's discuss diffuse large B cell lymphoma. So we discussed intermediate. Let's discuss a little bit about large B cell lymphoma. So it's basically a high grade and clinically aggressive one, right, of the B cells. It's again non-Hodgkin, we already know it. What would be the presentation feature? Presenting feature would be enlarging lymph nodes. That's so simple, right? Enlarging lymph nodes.
Yep.
This was all about non-Hodgkin lymphoma. Let's discuss Hodgkin lymphoma. So whenever the term Hodgkin lymphoma come in your mind, you know Reed Sternberg cells.
It's a mixer, yes.
What Reed-Sternberg cell do? It would release cytokines. Cytokines would recruit a lot of inflammatory cells within the lymph nodes. And a lot of inflammatory cells within the lymph node would cause enlargement or lymphoma. Is that clear?
Yes.
Okay. Okay, what are the cell markers for Reed-Sternberg cells? CD15 and CD30. Is that clear?
Yes.
It can further be divided into many types. Nodular sclerosis.
Can you repeat that concept, last one?
Yes. Okay, so the concept was Hodgkin lymphoma. What happens in Hodgkin lymphoma? Again, it's a neoplastic condition, right? What happens in Hodgkin lymphoma? We are going to see certain characteristic B cells, that is Reed-Sternberg cells, right? So, hello.
Yes, we are with
We
you.
hear you.
Okay. So we discuss non-Hodgkin lymphoma now. We are discussing Hodgkin lymphoma. What happens in Hodgkin lymphoma? The characteristic cells which we see in Hodgkin lymphoma, Reed-Sternberg cells. What's the what Reed-Sternberg cells would do? It would just release a lot of cytokines. A lot of cytokines are gonna attract a lot of inflammatory cells within the lymph node.
Yes.
If you have tons or lot of inflammatory cells within the lymph node, so can I say the lymph node is gonna enlarge? Hello?
Yes.
Yes.
The enlargement of lymph nodes is basically known as lymphoma,
Yes.
right? So there are different variants of Hodgkin lymphoma, right? We are going to see B cell symptoms, that is fever, chills, night sweats. You already know that, right? We are going to see a lot of inflammatory cells due to cytokines like lymphocytes, macrophages, eosinophils. You can see everything because these cytokines are going to recruit a lot of inflammatory cells. Is that clear?
Yes.
Okay, so can you just tell me like some of the different types of Hodgkin lymphoma?
Yeah, nodular predominant, nodular depleted.
Okay, so we have lymphocyte rich, mixed cellularity, and lymphocyte depleted. Where do we have best prognosis? Okay, so it's a kind of discussion. Like we are just left with the last topic which we are going to discuss today is plasma cell dysplasia. So I want to have a discussion because I think you guys are a little bit sleeping, right? So I'll just ask. Okay,
Sir, I have one question.
Abdul Rauf, yes.
Sir, I just have one question if you would be so kind.
Yes, yes.
Sir, basically you said that in the follicular lymphoma, the BCL2, they are knocked out and they are basically not allowing the caspases to come out and they are resting on the membrane.
Okay, so BCL2 normally. Okay.
Yeah, that they do normally. So if they are not, and in the book it's saying like that this disease result in overexpression of BCL2, which inhibits the apoptosis. So why is that precipitating this lymphoma?
Okay. You have already answered me, right? Okay, let's discuss normal. Normally what happens, for example, this is our mitochondria, right? Hello?
Yes, sir.
This is our cell. If I need apoptosis, okay, if I do not need apoptosis, what happens? BCL2 should sit there. BCL2 should sit there and it won't allow caspases, right?
Yes, sir.
If I want apoptosis, what happens? BCL2 should be removed.
Yes, sir.
Then caspases can come out and can cause apoptosis. What happens in this pathology? We are having overexpression of BCL2.
Yes, sir.
So what do you think? If I have overexpression of BCL2, can I see apoptosis?
No.
No. If I do not have apoptosis, cells won't die. It would exist. It would just cause a cancer. Cancer is simply, overgrowth of cells.
Okay. So basically, the more they are sitting there and they cannot cause the apoptosis, that's why we will have this cancer.
Yes.
Yes. Thank you, sir. Thank you, sir.
Okay. So, question for you people is that which variant of Hodgkin lymphoma show best prognosis? Lymphocyte rich or lymphocyte depleted?
The best lymphocyte rich.
Perfect, great. Okay, so let's discuss our last topic. I'll just discuss it. It's a kind of interactive topic, right? Multiple myeloma, a lot of MCQs. So, okay, so I want Dr. Arsh to open his mic, please, and tell us something about multiple myeloma. What is multiple myeloma? Okay, Dr. Daniela, can you just please tell us something about multiple myeloma? Doctor?
Which Daniela? Daniela, that's me?
Yes, you.
Okay, for multiple myeloma, I could just tell you the symptoms. There's a mnemonic we use, crabs, right? So they will present with hypercalcemia. They'll also present with renal failure. There will be bone lesion, like lytic lesions.
Okay. Okay, so basically, can I say that it's a plasma cell disorder? You're going to see like neoplastic proliferation of plasma cells.
It is.
Okay, if you are having plasma cell, what else are we going to see? As you just told us, it's a malignancy. It can spread through to bones. Right? It's a malignant condition. It has the ability to invade, to spread. So it can cause bone problems. Bones once broken, it can cause hypercalcemia, right? How do it cause hypercalcemia? Increase rank L, remember? Increase osteoclastic activity.
Yes, it will include
So plasma cells are abnormal if they are neoplastic, so they'll be producing immunoglobulins, but not like well enough, right? Not proper. So what happens? We are gonna see increased risk of infection. Why? Because this is neoplastic condition of your plasma cells, in which the antibodies being made aren't normal. We can see a lot of antibodies coming out in the urine. What's that? That free chain, the free chains of antibodies coming out in your urine. What's the name used for that?
Benz Jones.
Benz Jones protein. Perfect. You word MCQ. That free light micro proteins can also deposit in different parts, causing amyloidosis, right?
Yes.
What about Rolu formation or Rolex formation? Some of the people call it.
Because of
Increased
things.
serum protein. Perfect. Red blood cells stacked upon one another, right? Why? Due to less repulsion. Less repulsion can lead to stacking up of red blood cells on one another. So that was all for today's. If some topics are left, just I want you guys to do it by your own.
Doctor, can you repeat the last part, the Rolex formation?
Okay. So what happens in the Rolex formation is that as we are going to have a lot, okay. So if it's a plasma cell dyscrasia, neoplasia, so can I say that we are going to have a lot of proteins here, increased serum proteins, due to inflammatory proteins, right? Hello?
Yes, doctor.
Okay, if we have a lot of proteins, like a lot of proteins are basically negatively charged, right?
Yes.
Okay, so increased serum protein decreases the charge between red blood cells. So if you have a lot of proteins, simply you can think of the charge on red blood cells, the negative charge on red blood cells is decreased. So if the negative charge is decreased, the repulsion is decreased, right?
Yeah.
If the repulsion is decreased, it means attraction is more. So if attraction is more, it means red blood cells would attach to one another, they would attract one another. So it would just give you, red blood cells, attracting one another, and they will be stacking upon one another. And this structure is basically known as Rolex formation. Okay.
Doctor, can you just repeat why there are the bone lesions?
While there are
Bony lesions.
bony lesions. Okay. So it's a malignant proliferation. Remember, it's a malignancy, right? And that different malignant conditions love to spread somewhere. So they love to spread into your bone. Hello?
Yes.
So once they spread to your bone, what else they can do? They will activate the rank L. They will activate the osteoclastic activity. And once the osteoclastic activity is like increased, it would appear in the form of punched out lesions on X-ray.
Okay.
Okay. So.
Oh, sorry, doctor. I just had a last question. Could we clarify that both mycosis fungoids and HDLV1, which causes the ATLL, they're both associated with CD4 T cells, right? Not CD8. There's no association to CD8?
Yes. It's both of them.
Sorry?
Yes, it's associated with CD4, not 8.
Okay, thank you.
Okay. So I think that you guys should also take rest, and I'll also just take rest. Okay, you guys aren't going to take rest. You guys are going to have assessments, right? Assessments. So just wait for 1 or 2 hours. Just go to the Discord server. I'll be waiting there. Just do as much revision as you can, because we might select some people based on assessment score for the research as well. We are gonna make them head of research. Yes. So please do participate in the assessment, right?
Okay, Doc.
What time is the assessment?
Sir,
Okay. So
how the
just wait
assessment will be
for.
conducted?
Sorry.
How the assessment will be conducted, sir? Like in a live class, or will you give a
No, it's
link?
already. I think all the students are aware. It's basically on a like you'll just log in to. We will just share a link there. You can just simply attempt the assessment. Right? Everything is mentioned there. Don't worry about that.
Okay, sir.
We'll be just sharing a link of assessment. Go there and attempt the assessment and share your score. Right?
Okay, sir.
Okay, thank you so much. Hope you guys enjoyed today's session. If you guys enjoyed the session, please just drop down a feedback in the group what we can improve, or if you just like. Thank you so much. Thank you so much for staying here, for accompanying me, for making this class so much.
Thank you, Doc. Thank you.
Thank you.
Thank
Have
you,
a
Doc.
nice day.
Appreciated.
Nice day. Bye bye.
Thank you so much, sir. Thank
Bye
you.
bye.
Thank you.
Thank you so much.
Thanks, Doc.